2 3 check check. Hello 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 1 2 3 check 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 check. Hello hello 1 2 3 check check. Hello hello.
तिवारी अच्छा ठीक है ठीक है ठीक है विल स्टार्ट अभी बता रहा हूँ सर गुड मॉर्निंग with your permission sir we'll start and today it's been a great day again for our annual CME on pancreas. I'm blessed with the support of Dr. Agarwal and all faculty members, Dr. Pradeep Jain ji, and all delegates who participate and make our program success. So today we have an entirely focused program on pancreatic diseases, mainly concerned with pancreatic cancer. In the forenoon sessions, we have few interesting case scenarios, talks, lectures, and in the afternoon session, we have master videos and the highlight of today's program, the wet lab. The wet lab will happen in the hall B. Okay, so I welcome you all. And before I introduce Dr. Agarwal, who needs no introduction, who is just like a hero for me, for pancreas, who discovered pancreas in my life. Basically, he was a person who has driven the robotic surgery program in Gangaram and in this part of the country. And as you know, that Herophilus was an ancient Greek physician who referred to as the father of anatomy. He's father of pancreatic surgery for me and father of many other things who has guided us. And I believe each and every one of you should have a chance in your lifetime to work with him, to see his principles, to see how he works and take care of the patient with zero tolerance, as I mentioned in my last night's post on Instagram. So I request Dr. Agarwal to kindly come and address the audience and give the introduction about the CME.
इसका ये सेंट्रल माइक का क्या हुआ तो इको है ना हम एक बंद कर सकते हैं क्या Good morning everybody. First of all, on behalf of our institution and department of laparoscopic department is known as laparoscopic laser and general surgery, and I am very proud to be associated with the entire department which has set fundamental international guidelines in various domains of surgery. As Neeraj said, in pancreas also we became the first to do robotic pancreatic surgery in the country and robotic pancreatic surgery with natural orifice specimen extraction in the world. Neeraj has been extra kind to me. I think I don't suspect it as because of hierarchy, because I am heading the department and he's working there. That's the worry which comes to your mind. As long as you're sitting in the chair, you are pampered. But as they say, there are few relations in life which are non-transactional. One is mother and other is friend. All other relationships in life are transactional. So from the core of my heart, I feel Neeraj and me have no transactional relationship. So I take the compliments with like a blessing. So nothing would have been possible if we all know surgery is a teamwork. Together everyone achieves more, TEAM. Whether the robot was there, whether I was there, they were all useless. I alone was useless. So it needs a person who can translate ideas into action, who can support your thought process, and ultimately doing the things is more important than thinking about them. So all credit goes to Neeraj and Vasu. Vasu, where is Vasu? And entire team led by Neeraj. So thank you very much. I welcome you all on this rainy day and taking your time off despite the traffic concerns and rain, etc. I will not stand between you and the academics. So once again, welcome, and I request Neeraj to carry on with the proceedings.
Thank you, sir. Thank you. Where is he? बुला लो, बुला लो. ठीक है. So thank you, sir, and Vasu is here as you are asking. So yes, it is indeed a teamwork. Pancreas is not an organ where you can just fiddle around by yourself. You need a proper team for doing surgery, for aftercare and pre-care both. As we have a renowned team of our gastroenterologist, Dr. Sri Hari is here, and even radiologist to assess that whether the patient is operable or not. And I believe most of you are residents and few of them are faculties. Dr. Saab has come from Saharanpur and from MCD. So we are grateful for you. We're grateful that you have all joined us. So right now we're going to start with our academic program. Before we start, just hold on. चेंज नहीं करना. ठीक है actually. So we have a slight change since Aditya will be joining us soon, but we have Dr. Shri Hari who will be starting with the second topic as a first. Before I introduce my dear friend Shri Hari, you have to see this slide. Hans Chiari. Hans Chiari was an Australian pathologist who worked during a time when knowledge of pancreatic disease was still in its early stages. In the late 19th and 20th century, Chiari extensively studied acute and chronic pancreatitis, identifying the various forms and progression of the disease. His detailed description of the structural changes occurring in the pancreas during inflammation helped the foundation for understanding of pancreatitis and its causes. And the Chiari life and work remind us of the multifaceted nature of the medical research. So we have with us Dr. Shri Hari, who is as multifaceted as Chiari was, and he's an example where one individual can contribute groundbreaking work in more than one area, but often certain aspects gain lasting recognition. So Chiari's extensive work on the pancreas laid an important foundation for the future research on pancreatic diseases. So for the students and PGs, you all know he is also associated with the Budd-Chiari syndrome, which is, if anybody can tell me, what is Budd-Chiari syndrome? Yes, obstruction to the hepatic venous outflow. And also the Chiari malformation. It is related to neurosurgery, where there is obstruction of the CSF because of Chiari's malformation. So I request Dr. Shri Hari, who is as multifaceted as Chiari, to start with his lecture.
Thank you, Dr. Neeraj, for that very generous introduction. I wonder whether I really deserve that. So my topic, which I'll be deliberating over the next 20 minutes or so, is on pancreatic cystic neoplasms, and I think this is a very important topic for residents, students, and consultants as well, because this is a common problem which we face in our clinical routine, and this is one of, I think, still the gray zones where there would be a lot of controversy on what would be the best line of management, and there would be a lot of uncertainty whether you need to go in and operate or conserve or keep following up these lesions. So, my name is Dr. Srihari. I'm a consultant in the Department of Gastroenterology at Sir Gangaram Hospital. So, you're often faced with this dilemma that a patient comes to you and he's undergone an imaging for some disease, and the ultrasound or the CT scan shows that there is a cystic SOL in the pancreas. So, what do you do in such cases, right? So, why do you need to care about pancreatic cysts? Okay, so if you have patients with a pancreatic cyst, there is a very high chance, there is a more than 2/3% chance that you are dealing with a cystic neoplasm. Okay, and in these cystic neoplasms, 90% of these lesions are those lesions which are of clinical relevance, like IPMNs, mucinous cystic neoplasms, serous cyst adenoma, or SPEN. So these are tumors with great clinical relevance. So you need to understand and you need to know how to diagnose these conditions and what do you do with them, right? So what are the key questions when you are faced with a patient who comes with a cystic neoplasm, right? The first question that you need to answer is that what type of cyst is this? Is this a mucinous cystic neoplasm or this is a non-mucinous cystic neoplasm? This is the most important question that you need to usually answer. Then comes, is the cyst malignant? Is it malignant or it is benign, right? And the third one is, what is the likelihood that this cyst will progress to malignancy in the future? So these are the three key questions that you need to answer when you're faced with a patient with a cystic neoplasm, okay? So any patient who comes with a pancreatic cystic lesion can have varied diagnosis. On the left hand side, you see cysts like pseudocyst or a serous cyst adenoma. So these don't have any malignant potential. And here you can just do away even with surveillance. The patient, you only call back the patient if he's symptomatic. Otherwise, if not symptomatic, he can just leave the surveillance in such patients. In the middle, you have lesions like IPMN, that is intraductal papillary mucinous neoplasm, pancreatic mucinous neoplasm, mucinous cystic neoplasm, and SPEN. So these are cystic lesions which have definite malignant potential. Okay. So in these situations also, you can keep certain patients under surveillance or you can go up for a upfront surgery. If you have a patient with a cystic neoplasm who has a pancreatic ductal adenocarcinoma, obviously this is a malignant lesion and here you'll have to operate such patients. So you need to be very certain what you're dealing with, right? So if you see the general prevalence of these cystic neoplasms, the mucinous cystic lesions are quite common. So the mucinous cystic neoplasm is around 26%. You have IPMNs, especially the main duct type, which is 24%, IPMN branch duct type, which is around 19%. SPEN is relatively rare. Ductal adenocarcinoma is rarer if you compare all these cysts. Serous cyst adenoma again is common, around 18%. And you also have sometimes neuroendocrine tumors which are around 8%. So most common in the general prevalence would be serous cystic neoplasms and different type of mucinous cystic neoplasms, which could be mucinous cystic neoplasm or IPMNs, right? So when you see such lesions on radiology through various forms, there are certain morphologies that you see and identify, okay? So these are very important because all these cystic neoplasms would be having certain type of definitive morphology, which gives you a clue that you are dealing with this kind of lesion. You will either see a unilocular cyst or you would see a cyst which has multiple septi and there are microcysts and there is a central scarring. So this is very typical of a serous cystic neoplasm, the one on the top right, okay? You can see a cystic lesion which has macrocysts and very subtle septa. So on the left bottom, this is typically seen with a mucinous cystic neoplasm. And on the right bottom, you see a predominantly cystic lesion with no septi, but you would see some solid components. So whenever you see these solid components, that is when you should be very clear whether this is a malignant component. So whenever there is a solid component in a cyst, there is a high likelihood that you are dealing with a malignant kind of a neoplasm, and usually this would be seen like in a case of a MCN or IPMN, where you have a solid component within the cystic lesion. Okay, so I'll discuss the most important points about the various cystic neoplasms. First, coming to the serous cystic tumor. So this is usually seen in patients who are in the fifth to seventh decade, more common in females as compared to males. It is often or most often or almost always it is polycystic. So you'll see various kinds of cysts. So you see the morphology at the right bottom, you have a polycystic pattern where the different kinds of cysts, you have a honeycombing pattern where the cysts are of equal size, or you have a oligocystic pattern where the cysts are larger but there are relatively smaller number of cysts. So the thing with the serous cystic neoplasm is that it has a negligible malignant potential. So these can be just followed up. Okay. When you aspirate serous cystic neoplasm, the Ca levels are low. The Ca levels are very low, less than 5 or less than 20 in most of the lesions, and whenever you aspirate it, you will often see a bloody aspirate which is thin, which is not mucinous. Okay. And on the cytology, there are cuboidal cells which tend to stain positive for glycogen. Okay. And there are genetic tests now available which are very specific, and if there is a loss of chromosome 3p or VHL, so this is very likely to be in favor of a serous cystic neoplasm. Okay, the oligocystic kind of the serous cystic neoplasm is sometimes or many times it is confused with a mucinous cyst adenoma. That is where you have to correlate it with other findings, and that is where your genetic testing comes into play. Okay. So then comes mucinous cystic neoplasm. The mucinous cystic neoplasm is also seen between 5th and 7th decade. It is extremely common in females, up to 90% in females and only 10% in males. It is usually unilocular, and you will very often see calcifications in the wall of the cyst. And this is a cyst which has a definite malignant potential. So you don't miss these cysts when you're imaging. When you aspirate the cyst, usually you'll get a very high Ca, which is almost more than 275% of the lesions. And the cytology is columnar cells which have some urtypia, and the stains they are usually positive for mucin. And if you find a ovarian kind of stroma, this is pathognomic. Okay. And if you talk of genetic mutations, in these cases, KRAS mutation is very specific, but it might not be very sensitive for diagnosis of a mucinous cystic neoplasm. Okay. Then comes IPMN. The image that you see is the fish mouth sign, which is seen when you do a side wing endoscope. You see mucin just jutting out of the papilla and sitting there. This is like a fish mouth appearance, and this is pathognomic for a IPMN. So IPMN is seen in 5th to 7th decade. It is more common. It is usually equal prevalence in females as compared to males. You will see dilatation of the pancreatic ducts. You can see dilatation of the main pancreatic duct, that is the main duct IPMN, or you will see dilatation of the side branches, that is the side branch IPMN. So in IPMNs also, like in a mucinous cystic neoplasm, the Ca levels are high. Again, the cytology, you have columnar cells. The stains, they are positive for mucin, and again here you have KRAS and GNS mutations, which are very specific but might not be very, very sensitive. Okay. Then comes your SPEN. So SPEN is different. SPEN comes in the 3rd decade of life, and it is also very, very common in females as compared to males. Most of the SPENs are seen in the body and tail. They are thought to be lesions with uncertain malignant potential, but you have a large meta-analysis which now says that 20% of these SPENs are malignant. So the resection is the treatment of choice. The good part is they are very slow growing neoplasms and have a very good overall survival. Okay, so these are the basic facts about these most common cystic neoplasms of the pancreas. So what is the diagnostic armamentarium that we have to diagnose these different lesions? Okay, is there any role of blood biomarkers? So unfortunately we don't have any serum biomarkers as of now which can differentiate between these different kinds of cysts, or whether they can identify the cysts which have a potential for high grade dysplasia or cancer. In patients with IPMN, CA19-9 might sometimes be useful, only in IPMN might sometimes be useful to see if there is a malignant transformation. Short of that, you don't have any other biomarker. You have the CT, the most widely used and the trusted protocol. So in these cases, you would go in for a pancreatic protocol. So what is a pancreatic protocol CT? So you see the pancreas in the various phases. So in the early arterial phase, that is between 15 and 30 seconds, you see the vessels enhancing. And here you see the mesenteric vessels that are important on the left top over here. The mesenteric, whether there is involvement of the mesenteric vessels, that is over here. Then comes the pancreatic phase. In the pancreatic phase, the pancreas lights up, and you'd see the pancreatic parenchyma over here. Then comes the portal venous phase at around 45 seconds, where you would see whether there is involvement of any of the portal vein and the delayed venous phases. So all these things are important. The involvement of the mesenteric vessels, the pancreatic parenchyma that is involved, the portal vein whether is involved or not, and what is the exact status on this. The problem with the CT, the accuracy is not very good. It is not very accurate to differentiate between these different types of cysts, and you have the accuracy as per literature is around 63 to 73% with a CT scan. Okay, this is how a serous cystic neoplasm would look like. You see these multi-septated like a honeycomb-like appearance. A mucinous cystic neoplasm would be more uniform like this, and you would see calcifications usually at the in the cyst walls. The IPMN, you would see a grossly dilated pancreatic duct. Here you see a dilated main pancreatic duct, so this is a main duct IPMN. And in a spen, you will see a large tumor, which is usually in the body or tail of the pancreas. Okay. There are certain limitations to the CT scan. The limitations are that small cysts, especially the small cysts, we cannot see the details very clearly on a CT scan. The communication with the main pancreatic duct is a very essential thing when you want to identify a cystic neoplasm to characterize it. This is unfortunately not possible in all cases with a CT scan. And it is also not possible to differentiate between early invasive carcinomas versus carcinomas in situ when you do a CT for a pancreatic cystic neoplasm. Okay, that is where the MRCP might be more advantageous, because it helps us in evaluation even for small cystic lesions. It will tell you the fluid contents more better than a CT. It will tell us the relationship with the main pancreatic duct better than a CT. And obviously there is a lack of radiation exposure, and this is very useful because most of these cases you would be following these patients up, and you would need follow-up imaging in such cases, and that is why MRCP is useful. The limitation again with an MRCP is that calcification, which is a prominent part of many cystic neoplasms, is not very clearly seen on an MRCP. So this is how the lesions would look on an MRCP. You see a serous cystic neoplasm here, a mucinous cystic neoplasm, and you see a branch duct IPMN. So the difference here, the main pancreatic duct is not that enlarged, but you see these side branches which are enlarged. So different cysts, as we discussed, they have differing prognosis, right? So after doing a CT or an MRCP, sometimes you're still not very sure what kind of cyst you are dealing with. So this is extremely important, and it is even more important when you're dealing with a smaller cyst, because a smaller cyst which is less than 3 centimeters, you're still not very clear what would happen with this cyst in the future. So accurate characterization is still needed, and these two tests that we discussed might still not be very good in confirming what type of cyst we are dealing with. So why this dilemma is important? So because, see, when you're talking of treating a pancreatic cyst, and surgery is most often the treatment, you would want to avoid an unnecessary surgery. Suppose this is a serous cystic neoplasm and you thought that this is a branch duct IPMN and the patient undergoes a surgery. These are morbid surgeries. So you'd want to avoid an unnecessary surgery, but at the same time, you fear whether you're missing out on a malignancy, right? So you need something which is much more robust, much more clearer in what we are dealing with. So you need to have a closer look, a much closer look at these cysts to some other modality, and you would also want some tissue analysis, right? So this is the need that is required, and this is where a very important test like an endo ultrasound comes into play. An endo ultrasound has the capability to screen the pancreas from close distance, and it also has the ability to take tissue biopsies from the pancreatic cystic neoplasms. Okay. So what are the indications for EUS? So would you do EUS in all patients with pancreatic cystic neoplasms? There are many guidelines now. So definitely do a EUS if the size of the cyst is more than 3 centimeters, if there is a dilated main pancreatic duct which is more than 5 millimeters in size, or there is a change in the MPD caliber with upstream atrophy, or you see some solid component or a mural nodule in the CT or an MRCP. So here the EUS is a must. Okay. Also, the guidelines tell us if the cyst has been increasing in size by up to 3 millimeters to 5 millimeters per year or for every 2 years. So here again, you should screen these cysts with an EUS. Okay. Obviously, clinical parameters, if the patient comes up with jaundice, there is pancreatitis that the patient is suffering from because of a cystic neoplasm, there is lymphadenopathy, or there is an increase in a CA 19-9, these again are indications for doing a EUS in all such cases with a cystic neoplasm. When would you not do an EUS? Okay, if the cyst is very small, if it is less than 1 centimeter, no role of or no need of doing a EUS. If the cyst is arising in the setting of acute pancreatitis, very likely that this is a necrosis, a necrotic collection. Elderly patients who are poor surgical candidates, we are not planning a surgery anyhow, you might do away with a US. Or if you have a classical CT or an MRCP finding, which tells us with high certainty that this is this, and this is usually very rare that you will be very certain what you are dealing with, here you can do away with a EUS. Okay. So how good is EUS in identifying the different cyst types? Okay. So based on morphology alone on the US, the sensitivity or the accuracy of the US is again not very good, it is around 50%. But if you have to differentiate between a mucinous versus a non-mucinous neoplasm, the sensitivity and specificity is somewhere around 60 to 80%. And the biggest important point is there the inter-observer agreement when two people are doing an US might not be very good when you are doing a US to identify the different kinds of cysts. Okay. But how good is EUS at identifying high risk lesions? So this is very important. You need to find out if the cystic neoplasm has some high risk lesions like a mural nodule. So here the EUS is really very good. It is much more sensitive than a CT scan to identify high risk lesions within a cystic neoplasm. So this is where EUS really helps you a lot. So the dilemma often is whether you are dealing with a mural nodule or a mucus globule. Okay. So if you see these two pictures, a mucus globule would be hypoechoic, whereas a mural nodule is usually iso or hyperechoic. It has smooth edges, whereas a mural nodule has rough or irregular edges. And there is a hyperechoic rim when you do a EUS for a mucus globule, whereas for a mural nodule, this hyperechoic rim is absent. So this is a good way to find out whether you're dealing with a mural nodule or a mucus globule, because a mural nodule is definitely a marker for malignancy, a mucus globule is not. Okay. There you also have the option to do a contrast harmonic EUS, and this is very, very, very sensitive to differentiate better whether you are dealing with a mural nodule. So if you do a contrast harmonic EUS, you would see that the lesion just lights up with the contrast, whereas a mucus globule would not take up the contrast. So here it's very sensitive and very specific to differentiate between a mural nodule and a mucus globule. Also, when you're doing an EUS, you have the ability to screen the entire pancreas. Like in this case, the most of the imaging would be telling you that you have a grossly dilated pancreatic duct. That is okay. Okay, but when you keep screening, you might pick up small lesions like this, which are associated adenocarcinoma on the EUS. So that is also a very good advantage of the EUS. Okay, next comes a very important aspect which the EUS enables us, and that is evaluation or analysis of the cystic fluid. So when you have the cystic fluid and you are able to aspirate it, the IPMNs or the mucinous cystic neoplasms have a very high level of CEA. And of late, the glucose has also been found to be a very, very important test to differentiate between IPMNs and serous cystic neoplasms, or MCNs and serous cystic neoplasms. So glucose is very low in these mucinous neoplasms, whereas it is high in serous cyst adenomas. And this is found to be a very useful test. You just send the fluid glucose for analysis and you'll be able to find out what it is. Obviously, you have the ability to do a cytology in all such cases. And there has been a recent paper published in GI Endoscopy 2021, which tells us that the sensitivity of glucose, cyst fluid glucose, even outweighs the sensitivity of the CEA in the cystic fluid. And this might be a very useful test in differentiating between these different cystic neoplasms. Okay. So apart from this, there is something called as a microbiopsy forceps. So you would want to take biopsies from these mural nodules sometimes, and it might not be possible with a FNA needle. You have a microbiopsy forceps by which you can pinch these solid components and send it for evaluation. So EUS biopsy is also found to have a good diagnostic accuracy of around 80% in diagnosing these different malignant neoplasms. There is some small risk of bleeding and pancreatitis, but it is an acceptable risk. Okay. You also have genetic markers. So you have aspirated the fluid, or you have created you have made the cell block, and you can send these samples for genetic testing. So if you have a GNAS or KRAS or a BRAF genetic mutation positive, it has a good sensitivity and a very high specificity for IPMNs or mucinous cystic neoplasms. On the other hand, VHL genetic mutation is seen to be very specific for a serous cystic neoplasm. Okay, not only differentiating between the different kinds of cyst, but also to predict the risk for high-grade dysplasia or cancer in such patients. And this is a very, very useful test, that you have a genetic markers now available. Usually these are standard panel of tests that are available at certain centers, where you can run these panels and you can differentiate between the cysts. You can also find out their malignant potential. So for malignancy, you use MAD4, TP53, cantamine gene and mTOR gene to differentiate whether there's a risk of malignancy or not. So you have done these molecular markers now, and you have a KRAS, GNAS and BRAF gene, which is indicative of a IPMN or a mucinous cystic neoplasm. But you also have seen that it also is positive for TP53, SMAD4 and mTOR genes. So this is a malignant mucinous cystic neoplasm. You would opt for surgery in such cases. Okay. If you just have a KRAS, GNAS and BRAF gene, this is a mucinous cystic neoplasm with no malignancy or high-grade dysplasia right now. You can consider surveillance in all such cysts. If you have a VHL positive, this is a serous cystic neoplasm. This patient can be discharged. Obviously, this is when you're not very certain morphologically, and you need to use these genetic markers in such cases. So what is the treatment option? Now you have done all these tests and you are certain about the diagnosis of the cystic neoplasm. What is the treatment? Okay, so there are many guidelines which have come up for management of pancreatic cysts over the years. The 4 latest guidelines that we usually use in practice are these AGA guidelines, American College of Gastroenterology guidelines, Fukuoka guidelines, and the European guidelines, which came in 2018. Okay, so when we are talking of surgeries or management of these pancreatic cysts, there are these common concepts that would be useful. So if you have a symptomatic pancreatic cystic neoplasm, irrespective of its nature, it will have to be operated, right? If there is an associated mass, again, irrespective of its nature, it usually often will need surgery. Okay. Who do you put in surveillance? If the patient is a surgical candidate and is willing for surgery in future, only there is any point of putting this patient under surveillance, because obviously the surveillance will run for life. Okay, and also if the patient is willing for systemic therapy, those are the patients you would like to put on consider surveillance in all such patients. Okay, the surgical options that as the surgical faculty, I am sure that you will be more aware than me. For head lesions, you would go in for a Whipple's. For a distal body and tail lesions, you would prefer a distal pancreatectomy. And for small central lesions, there is also an option of doing a central pancreatectomy in such patients. Okay. For serous cystic neoplasms, we saw that serous cystic neoplasms don't have any malignant potential. So surgery is recommended only if a serous cystic neoplasm patient has symptoms, which is often due to compression of adjacent organs, like it is compressing on the bile duct, stomach, duodenum, portal vein, etc. Asymptomatic patient with a serous cystic neoplasm, you will do one follow-up at 1 year. After that, there is no follow-up unless the patient becomes symptomatic. So serous cystic neoplasms can be left just like that. Okay, if you have a mucinous cystic neoplasm, any mucinous cystic neoplasm which is more than 40 millimeters should undergo a surgical resection. Okay, resection is also recommended for mucinous cystic neoplasms which are symptomatic or have risk factors like mural nodule, irrespective of their size. All other MCNs can be kept under surveillance. The first surveillance is at 6 months and then yearly, and then you continue this for life. MRI and or EUS are the recommended modes for surveillance of such patients. For IPMN, there are a lot of, there is a jargon of information, how do you do this, but I found this table to be the most useful when you are thinking about management of IPMN patients. So the absolute indications for surgery in IPMN is you have a positive cytology for malignancy or high-grade dysplasia, if it is associated with a solid mass. If it is associated with jaundice, jaundice should be because of the tumor, not because of something else. You have an enhancing mural nodule which is more than 5 millimeters in size, and you have an MPD dilatation of more than 10 millimeters. There are some relative indications, like the growth rate of the tumor is more than 5 millimeters per year. There is an increase in the level of CA19-9. MPT dilatation is somewhere between 5 millimeters and 10 millimeters. The cyst diameter is more than 40 millimeters. There is new onset of diabetes. There is an acute pancreatitis because of the obstruction caused by IPMN, and there is an enhancing mural nodule, but the mural nodule is less than 5 millimeters. So these are the relative indications for treatment of IPM. For SPEN, complete resection is the treatment of choice, and you would sometimes see synchronous metastasis. So the resection of these metastases is also recommended whenever possible, and it has a very good prognosis. So, ladies and gentlemen, my take-home message from this is that these pancreatic cysts are very common incidental findings, and different pancreatic cystic neoplasms have different natural history and prognosis, right? So that is why an accurate evaluation with a CT or MRI, and especially EUS, is an invaluable tool due to its tissue sampling ability. The benefits and risks of surgery should be considered in every case, and it should be offered only in patients who are at high risk, and if you are dealing with a malignant pancreatic cystic neoplasm. Thank you so much. Yes. Thank. No. If I've written that, I'm wrong on that. Let me just check that.
Slide has shown that. So I just want to make clear.
No, sir. It's less than 192. It's less. It's less.
Oh, so I read that.
No,
sorry,
no.
I read that more than 182. Sorry.
So I think if with the advent of US now you are able to do that very clear, and you most often than not you will not have cysts which are very large and there is a lot of fluid available. You will be having these smaller cysts where hardly 2, 3, 5 ml of cyst can be aspirated. I think the US is much more useful, much more better in doing that rather than doing a percutaneous aspiration.
Thank you very much, Neeraj.
Thank you, sir.
Excellent.
Thank you, sir.
So educative for me, at least.
Thank you, sir. My pleasure.
Thank you. And thank you everyone for joining us here again. So before we go to our next speaker, so here's a story again of Paul Legerhans. So he was a medical student. As you all know, that Paul Legerhans is the person who first identified the islets of Legerhans while he was writing his thesis work. He was just 22 years of age at that time when he discovered these structures in the microscopic anatomy of the pancreas. And he labeled them as probably they are a group of lymph nodes, because the exact function, the exact nature of these special cells was unknown at that time. And ironically, at that time, his discovery did not realize the profound significance of these tiny clusters. It was only many years later these tiny clusters were identified to produce insulin, and which was a breakthrough in the treatment of diabetes and the pancreatic diseases. And again, our twist in the story was he suffered from tuberculosis at a very early age, and he moved to a town in Portuguese in hope of improving his health. But he died at the very young age of 40 years. So yes, this is a tragic story, but yes, young achievers like him are known, and we have a young achiever with us, Dr. Aditya Sareen, who is also as multifaceted and inspiring research person. He is our oncologist here. I request Dr. Aditya to kindly come and give us insight about what the literature says about pancreas today. Thank you.
Thank you, Dr. Neeraj, for a wonderful introduction. So, a very good morning to all of you. And obviously, the topic which I was given, it was what's the recent literature, and a review of high impact articles on pancreatic cancer. So, to be honest, when I started this and making these slides, I came to realize there are more than 100 impact journals and hundreds. So there was a lot of information, and obviously I'll try to be as concise and as point specific as possible. So without wasting further time, let's start for the next 20 minutes. What's the recent advances and what's happening around us in the pancreatic world? So overall, if we see that to the tunes of, just a second, let me have my pointer. My slide's not visible, right? Technical team, can I have your support? Yeah. So anyways, I think in the meantime, the technical glitch is being sorted out. We know that the cancer is on rise. Most of us here, if we were 20 years back, this term would have been somewhere, less frequently used and, not that much used. But now the burden is increasing at an alarming rate. We have approximately 19 million new cases, and we have 10 million deaths worldwide. And the pancreas contributed overall rank 12th in the new cases, and in the death it contributed number 6th. In India, we have approximately 14 lakh new patients of cancer, and pancreas comes out to be at the list number 23rd. And this is what generally we see the patients when we have patients with the pancreatic cancer once the clinical staging has been done. So you can see any tumor which is more than 4 centimeter at the end of 60 months, there is a probability of survival is to the tunes of less than 25%. And if the nodes are positive, the higher number of the nodes are positive, the survival goes way, way down. So pancreatic ductal adenocarcinoma, it's the most common in the form of the exocrine, and most common is the adeno. And the median 5-year survival for the early stages, mind it, I'm using the word early stage, not even for the advanced stage, it is just 25 to 30%. And most pancreatic adenocarcinoma are diagnosed at an advanced stage. And think about a country like India, where my practice is to the tunes of 90%, I'm seeing just metastatic disease upfront. So what is the current 2024 estimate that the leading sites of the new cancer cases and death? It is to the tunes of 3%, and in the males to tunes of the 8%. So these are the current facts. So overall, less than 12 months median OS is typically reported. Patients are generally found to have poor prognosis, and 2 to 6 months of median OS for metastatic pancreatic cancer, 11.5% median 5-year survival rate, and more than 80% have advanced disease at diagnosis. Hence, it makes it one of the worst malignancy to deal with. So how do we get it? It can be in the form of sporadic, familial, or hereditary. So in the familial, only 10 to 20% might have a germline mutation, but it might not be necessary. So familial tumors are those tumors where the cancer is running through the families, irrespective. Sometimes you may be able to find a gene, germline, but sometimes you will not find a gene. The estimated lifetime risk is around 15% for individuals with 1 or 2 first-degree relatives if diagnosed before the age of 40 years. And what about hereditary? So enormous amount of research has undergone here, and we have been able to identify mutations like BRCA1 and BRCA2, mutations like mismatch repair proteins, CDKN, APC, STK11, and multiple more mutations. Only 3.5%, so how about the prevalence? So 3.5% of the patients had sporadic pancreatic ductal adenocarcinoma, 5.5% had pancreatic ductal as per the JAMA trial, And so you can just see the prevalence of the germline mutation varies from the region to region and from the population, just from 3.5% to 17.5% as per Benin et al. So then came the implementation of the panel testing for pancreatic adenocarcinoma, and they incorporated these major genes: BRCA, ATM, CHEK2, BRCA1, CDK, and TP53. And now NCCN also suggests the same, that we have to do this. So what was the timeline? In 2005, there was the first mention of pancreatic ductal adenocarcinoma and the germline testing. Then in 2009, consider the diagnosis for the germline testing. And now in 2019, we have the recommendation of going for the germline genetic testing for pancreatic ductal adenocarcinoma. So what adoption of genetic germline testing needs is the point of care testing by the oncologist, group genetic counseling, embedded genetic counseling clinic, and I'm happy to say that we have good amount of genetic counselors over here, and the genetics education video with the post-test genetic counseling follow-up. So this was one of the most impactful trial which happened just at the time of the COVID, where MD Anderson launched a pilot protocol of genetic education counseling, and it had 100% consent post-pandemic. So generally we were of the thought that the patient has to be seen, but with this trial of MD Anderson, they made sure that the implementation of a video-based remote germline genetic testing for individuals with pancreatic ductal carcinoma, adenocarcinoma can be done. So how about the lifetime risk if one person has any of these genes? So you can just see the BRCA2, it has 5 to 10%, and for the STK11 it has more than 15%, and ATM it is 5 to 10%. So high risk individuals are generally, we consider those where you have a more than 5% lifetime risk of pancreatic ductal adenocarcinoma. And these are all the guidelines. So once you have these mutations, so most aggressive one is the STK11, and you start your screening at the age of 30. And gradually for CDKN2A 40 and ATM and BRCA2 for 50. Or 10 years or earlier than the first degree relative history of pancreatic cancer. So how to screen? So technically there is no gold standard as of this moment where I can say, but yeah, we have diagnostic modalities like MRCP and EUS. CA19-9 is like the most extensively evaluated blood-based biomarker, but it has a limited specificity of only 6 to 20%. So this was the meta-analysis done of 13 trials, which said that there was no serious harm from initial screening, and there was no evidence of psychosocial harms related to the screening. What all screening protocols trials use, some did MRI, some used EUS, some did a combination. So at the end of the day, even the meta-analysis suggested that you are supposed to screen the high risk, whichever technology you are using, that is fine. So what is the benefit that we are driving? That at the end of 3 years, 85% overall survival rate was seen in patients with pancreatic ductal adenocarcinoma diagnosed in high risk individuals. So if you have a patient having a high risk, you need to start their screening. That's the most important point. So this was the CAPS recommendation. It's again states the same. And obviously diabetes, it's again a pandemic. 1 in 100 patients might land up with the pancreatic ductal adenocarcinoma in the following up of 3 years. What about the recent biomarkers? So we have IMM-RAE PanCan-D test with an 8-plex biomarker signature. It's in the evolution. Cancer-Seq is again, it's a blood test that can detect the 8 common cancer types. And another test by Nakamura et al. With utilized 13 microRNAs. So what's the best point to deal with pancreatic cancer? It's before the cancer develops. Obviously we want our general population, then we stratify the population into the high risk population, and features like higher grade pancreatic intraneoplasia and IPMN, MCMN, I think my gastro colleagues are well versed, to able to pick such kind of malignancies where we say that these patients have high preponderance to develop further having pancreatic adenocarcinoma. So what they did, they used CF, which is the cell-free and exosome microRNAs, and a signature of CA19.9 to analyze this. Technical team, having a lot of glitches today, huh? So at the helm, we have so many markers right now, like circulating tumor DNA, cell-free DNA, we have microRNAs and exosomes, methylation. It's the next and upcoming way to diagnose the cancer as early as possible. So this is where we are heading, and So you can just see the amount of research being done in order to have early detection rate of the pancreatic cancer. So this was the trial done by Nakamura et al., and which definitely had an area under curve of 0.98 and 0.93. Anything which is more than 0.5, we are happy with that. So what all came out of this was that pancreatic ductal adenocarcinoma becomes a universal genetic testing. Video-based testing is also applicable, and multidisciplinary approach should be taken, and multi-institutional research effort should be done. So what about the reality? Once you have the patient of pancreatic adenocarcinoma, what all plethora of options you have, or the oncologist has? So the chemotherapy in the palliative setting in the form of FOLFIRINOX, gemcitabine again. So now this new drug, which is the nanoliposomal irinotecan, I'll be discussing this as well. So pancreatic cancer is a particularly challenging disease, this we all know. There have been very few success stories in pancreatic cancer, and mostly we have the failure. So you can see in the last 9 years, we have 20 studies which have failed of a different combination. And why is that? Because pancreatic cancer is difficult to treat in view of the dense stromal layer, immunosuppressive tumor macrophage, and low macrovascular density. So these are just summary of phase 3 trials in the metastatic setting, which is established. There is no question about it. The PRODIGE trial, the PRODIGE Accord, and the POLY trial. So these MPACT trials, so these are done in the metastatic setting where different drugs like gemcitabine or nanoliposomal irinotecan have been used. And you can just see the median OS over here. So it is ranging from 11 months in the experimental arm to in the placebo, in the convention, in the other arm, it was just to the tunes of 6.8, 8.5 versus 6.7. So the maximum in a metastatic setting, the first line was able to offer, it was up to a year, even less than that. Again, in adjuvant setting, the roles of these drugs like gem-cap regime or a gemcitabine regime has been established. There is no debate about it, and you can see that the median OS, once you give a gem-cap kind of a regime, it's to the tunes of 28 months. And if you give a FOLFOX-based regime, it's to the tunes of 53.5 months. Again, you have lots of data, and lots of data is coming up in the adjuvant setting as well. So this was the Accord trial, which showed FOLFIRINOX and established it 11.1 months of PFS benefit, and the gemcitabine-based arm was having only 6.8 months. What about the MPACT trial? It was gemcitabine and nampacli, which we are using day in and day out. It showed a benefit of 14.8 months as compared to 11.1 months. So the most recent one is this Napoli 3 trial, where they incorporated the first line metastatic adenocarcinoma pancreas, and they used this drug. Irinotecan has been there for past 20-30 years, but now the technology is advancing, and they use this formulation, which is liposomal irinotecan, and the protocol is known as NALI-IRI-FOX. So why is this important? Because NAL-IRI with the innovative pegylated nanoliposomal delivery enhances the anti-tumor effect because it has a lipid bilayer. So you have the outer bilayer of the lipids, which prevents the irinotecan into the early conversion of its metabolite, which is to the tunes of 95% of irinotecan remains stable during the circulation. And once it reaches inside the tumor, then just it open up. So there is a less chance of having side effects to this drugs as well. So the drug, which is Onivyde, again liposomal irinotecan, it has less side effects, circulates into the body with a poor blood perfusion at the pancreatic tumor, reduces the effectiveness, was the part of the conventional. But this drug makes sure that the drug keeps for a longer duration inside the tumor, and hence giving you a better peak of the concentration of the drug inside the tumor. And you can just see that at the it is 3 times stronger than the original irinotecan. So the first trial was done in Napoli 1, and then in the second line, and then it was done in Napoli 3. So what was the ORR? It was to the tunes of 41.8%, and you can just see the partial response to the tunes of 41%. So this is the first line management of metastatic adenocarcinoma pancreas. with the benefit of to the tunes of 2 to 3 months. And if we compared it with the placebo arm or the Gem-Nab-Paclitaxel arm, we have the benefit to the tunes of 17%. If we compare our original protocols, FOLFIRINOX versus the NALIRIFOX, the median OS remains the same. The OS at 18 months is higher with this nanosomal liposomal irinotecan, and the frequency of neutropenia, you can just see, it is 23% with the nanosomal lipo-irino, and with FOLFIRINOX, where the conventional irinotecan was used, it is only 45. It is higher, 45%. So we don't want our patients to crash down. We want our patients to tolerate the chemo as easily as possible. So we want less side effects. So this combination has helped us to achieve that kind of a scenario. And if we compare all the three together, you can just see that it's a fairly well tolerable drug, with the response rate being highest to the tunes of 42% in the Napoli 3 trial, and the neutropenia was 14%. So going into the molecular and immunotherapy, because no discussion is going to end here without discussion of the molecules and what are different drugs we are using here. So if the patient is having a high risk gene like BRCA mutation, we have these drugs now like olaparib. And for patients with MSI high or DMMR, we can use immunotherapy, and mutations like NTRK fusion, we have drugs like larotrectinib or entrectinib. So these are the latest guidelines. If the patient is having these mutations and the patient is in the locally advanced stage, that means that the patient is unresectable, we have to do an NGS comprehensive genomic profile in order to get this information upfront. If we can have these kind of mutations like NTRK or BRAF or MSI high, we are not supposed to give them chemo. We can definitely offer them these kind of drugs. Obviously, the limitation over here is that the frequency is far less. Hardly in my practice I have yet to see those kind of patients where the NGS upfront has been done and then again found to have a mutation. Again, in the metastatic setting, where obviously the surgery has no role, we have again these drugs, larotrectinib, repotrectinib, again, so the role of mutation comes in the locally advanced as well as in the metastatic setting. Now what happens if we see our patients having a good control onto the chemotherapy and patient remains stable? So the recommendation is that after 4 to 6 months of the chemotherapy, patients can undergo a chemo holiday or a maintenance therapy. And now, with these innovations and new drugs being available, we can use olaparib in a subgroup where the patient is under good control and the patient is found to have a germline, that is the test to be done in the blood, not on the tumor tissue. We can use this drug olaparib, and the reason is this, because of the POLO trial. Now POLO trial, again a randomized RCT, it was a phase 3 trial which randomized the patients as per the BRCA. Obviously every patient had to have a BRCA mutation, whether it be BRCA1 or a BRCA2. More than 16 weeks of first line platinum based therapy should be there, and this was the result. The PFS nearly doubled here. So we were able to identify out of so many pancreatic ductal adenocarcinoma a select subgroup with BRCA mutation where the PFS can be doubled with just the help of a single tablet. There was a 47% reduction in the relative risk of disease progression or death. You can see the estimated proportion of patients who were progression free for 24 months. It was 22% of the patients were free. As compared to the other arm, it was only 9%. What about the response rates? So well, Lynparza had an OR of 23% and placebo had an OR of just only 12%. So again, if we compare it technically, it's double. For a patient who responded to Lynparza, the median duration of response was more than 2 years after the platinum therapy. And what all rest of the biomarkers and what all rest of the drugs we are analyzing, technical team, today something, breakfast has not been served to you, huh? Okay. So biomarkers, we have NTRK, MSI high, TMB, RET mutation, and we have the drug for this which is known as sulpercatinib, and for the BRAF mutation we have dabrafenib and trametinib, and now the new kid on the block which is the TDXD, which is trastuzumab deruxtecan. It's available in India and we are using it, day in and day out as per the requirement. So these all drugs have been approved. Now what if the patient has progressed on the first line? What all options do we have? Obviously we need to go for the NGS if not done in the first line and recheck your mutations. And if you have an IHC value of 3+, you can definitely use this molecule which is deruxtecan. So overall, FOLFIRINOX or NALIRIFOX or GEM-Abraxane, these three salts or the three regimes are the main first line therapy. And the DNA repair defects caused due to the BRCA1 and BRCA2 mutations, you can target them with the help of olaparib. And the KRAS mutations, we have this drug now by the name of adagrasib and sotorasib. Again, the trials are ongoing and sooner these drugs will definitely come into more regular use. So while I was going through, so this was the latest ESMO update which happened in Munich on 29th of June 2024. Generally, whenever we see that the patient is having even a single spot outside the realms of the regional boundary of the pancreas, we tend to say that this is a metastatic disease, that's it, no role of surgery, no role of any locally ablative treatment, you just go with the palliative chemotherapy. But now a lot of research is being done into this concept. It is there in lung, it is there in sarcomas, it is there in breast tumor, but now it is spilling over to the pancreatic tumors as well, the concept of oligometastatic pancreatic cancer. So where a cancer comprises a biologic spectrum extending from the disease. So for example, if you have a pancreatic lesion and let's say there is only one lesion in the lung, that constitutes an oligometastatic disease, or there is a one lesion in the liver, again an oligometastatic disease. So ideally, what should be done for such kind of a case? Conventional teaching is treat them as metastatic, but this is changing. Ductal adenocarcinomas are a systemic disease, we all know, because it has a preponderance for early dissemination. Neoplastic property spectrum along a continuum, it has a contrasting and dichotomization of local versus systemic adenocarcinomas. Oligometastasis happens due to the clonal dominance of cells with limited metastatic capacity. So just for an example, if you have a widespread disease, obviously we'll be looking towards a palliative intent. But if you have a spot like this, like if one lobe of the lung is involved or the lower lobe is there, or just two lesions or one lesion, so there are various theories. There can be a graduated or a punctuated evolution, but at the end of the day, we tag it as an oligometastatic. So while I was training, till that point, there was absolutely no studies being done to assess the roles of oligometastatic. And after 2015, studies, RCTs, phase 2 trials, phase 1 started to do the studies on the oligometastatic. And what all they were able to analyze was, so this was the German trial with the prognosis and tumor biology of pancreatic cancer in isolated lung metastasis, where 66 patients had a metachronous isolated pulmonary mets, where they did the resection of the pulmonary met and that of the primary, and they reported the median OS to the tunes of 33 months. Whereas, where no resection of the lung mets was done, it was to the tunes of only 19 months. So they were able to analyze that if you have less than 3 number of pulmonary mets, the size should be less than 5 mm, or the location of pulmonary met should be unilateral. Resection of the pulmonary met should be the ideal way. You can definitely find your very select subgroup where you can go for the upfront surgery of the primary and as well as the metastatic deposit. So generally, once we tell these outcomes or these kind of treatment to the patient, so they go to another center who are not that much aware of the data. So generally they come back, doc, उन्होंने तो ये बोला था कि जी हमने तो सर्जरी नहीं करानी, आप तो मेरे को ये कह रहे हो कि आप सर्जरी भी कराओ और वो भी रिमूव कराओ, आपके पास डाटा क्या है? Obviously इस स्टडी से पहले हमारे पास कम था, but now evidence is so much. We can use surgery of both the primary and as well as for the metastatic site. So again, a study from Tysera et al. Again presented in 2023, where only 39 patients were analyzed with the lung-only relapse, and you can see even there the OS was more in the patients who were given the upfront choice of resection of both the primary and the metastasis. What about the conversion rate? You can just see if the patients were given neoadjuvant chemo upfront in such kind of scenario in the oligometastatic, you have a median OS of 8.1 months. With the resection of the primary and M1 side, you have 25.5 months. And if after giving the chemotherapy, the tumor has gone, that is the best case scenario. You have a 2-year survival rate of 58%. And if the tumor has not gone into the resolution, if the tumor is still there and you have resected, the survival rate goes down. It goes to the tunes of 25.4 months. So you can pretty well identify which kind of patients are going to be most beneficial for your surgery of the primary and as well as the metastatic disease. So the synchronous metastatectomy in another trial, in another area, showed a median OS of 10.6 months. In metachronous, it showed a benefit of 14.8 months. So what did the IAP JPS consensus statement? That surgery first approach should not be advisable with simultaneous pancreatectomy and hepatectomy. Oncologists can help you to shrink down those tumors. If we suspect that the patients are going to land up with the CR of the metastatic deposit, we can just put a clip. And at the time of the surgery, once we feel, we can just take both the things out. So advisable to plan simultaneous resection if liver mets do not progress with intensive chemotherapy, and convergent surgery in select patient may have a survival benefit. So this was the latest ESCO GI 2024 extend trial, where they utilized this surgery, and they did metastatic disease directed therapy and a systemic disease directed therapy, and they were able to give a benefit of approximately 12 months vis-a-vis 10 months. This was the OS, but look at the PFS. It is to the tunes of 10.3 months, and the standard of care PFS was only 2.5 months. So what we all need to do is that we have to have a select subgroup identification of which kind of plan should be done. So every patient is different, and the plan should be made in respect to the, that what I say in my practice, that patients are the, main pillar for us. They have to become a part of the decision making. Obviously, such kind of oligometastatic pancreatic ductal adenocarcinoma, huge randomized trials are going to take way too much time for us to get an answer. But yeah, at least now people are doing it and we are getting the result. So an optimal medical decision is the one that integrates information about the patient, clinical state and circumstances, the available research evidence as well as the patient's value preference, including the patient's preference, should be defined in decision making, while decision making. So in summary, I would just like to say that some evidence supports the idea of oligometastatic pancreatic cancer. Increasing number of studies investigating the oligometastatic cancer is increasing, and obviously the systemic treatment is there. It remains the standard of care, and the metastasis directed treatment of potentially oligometastatic disease is currently right now in the realm of clinical trials, but data is promising. So with this, I thank you. Ma'am.
Since we have an active department of radiation therapy, I think local RT and SBRT should be a part of that. Like you said, metastatectomy and less than 5 oligometastasis. Would you go and do metastatectomy on all those 5?
So if I have to say, categorically, obviously, if resectable, I will be happy to go for a resection. If the surgeon is so confident that I can remove all the 5, at the end of the day, resection will always tend to amount in a better result. If for some reason those 5 lesions are not going to be resectable, then obviously we can go for SBRT.
You are talking about 5 oligometastasis in one organ. What about if you have 5?
So to be honest, we have never seen such kind of a patient obviously in pancreas, number 1, where we have 5 oligometastatic.
You have a lung and and liver. You can have both, isn't it?
Agreed. So I'm saying it depends
So
upon
you
the
have to also
location.
tell the morbidity. You know,
Agreed. So there is
so
no
what
doubt
I
that.
want to say ki, I mean, you have not presented any data on.
Yeah, absolutely.
radiation
The
therapy.
reason for
So
that is I
in
thought that the radiation people will take about that chance.
No, you've taken up the surgery part.
No,
and
no. I took
don't
up
want
the.
the audience to go back. There is no role of radiation.
No, I'm not saying that. At any point, what I'm trying to imply is surgery is the best. Yes, if surgery is not possible and we are still contemplating in the realm of oligometastatic, then you have to go for the radiation, which in the form of SBRT, that radiation people are better able to say, and then see
Yeah,
which subgroup we are talking,
yeah,
it's
what
very
I'm-
less.
What I'm
It's
trying
very
to
less.
say, the oligometastasis thing came from the COMET trial, isn't it? Ki,
So I just showed
yeah.
the
So now
German
with
trial.
the data coming with SBRT and target therapy or immunotherapy, we have much better results.
Okay,
isn't it?
so if I have to say surgery versus SBRT and the surgeon says I am comfortable in taking out 3 lesions, correct? Where will you tilt? Surgery is always better, resection is always better if it is resectable.
No, I'm just incorporating the radiation part in it. So I think it is not. There is another. Yeah. Yeah, I mean that is there in many. It has come up in many other organs.
So obviously if the patient is having, let's say, a lung lesion or a liver lesion or a bone lesion, so 3 lesions, nobody is going to take all the 3 lesions out. Even we know that. Even everybody knows that. But if there is only 1 lesion in the lung or 2 lesions in the lung or 2 lesions in the same lobe of the liver, one can easily take them out. It is pretty much resectable. If it is not, then obviously we are happy to go for radiation, and this is what we have been doing for the rest of the malignancies as well. But if you have a head-to-head comparison trial where surgery or we prove that the radiation is non-inferior to the surgery, then obviously our practice will change. We need to have a non-inferiority trial that the surgery and the radiation are comparable. I'm happy to change the practice.
No, I'm not disputing that. Like there was not a word of radiation. in
I
your
know,
lecture.
there was.
That is why I have just put up my comment so that
Yeah,
people
yeah.
know about there is another option. There is another option.
Agreed. I mean, we all know
Only
that.
I'm not
Yes, sir. Amitabh, sir.
disputing whatever you have presented.
What in your practice, what is the percentage of patient who reaches a surgical resection? We treat borderline resectable pancreas now because earlier we used to say that they are not unresectable
Yeah.
and just go for chemotherapy.
Right.
Last 10-15 years, the concept of borderline resectable pancreatic cancer has come up, and we usually tend to send these patients to chemotherapy for just to downstage the disease.
Absolutely.
But in your opinion, what is a percentage of patient who reach the surgical
Where we have been
resection
able to after
chemotherapy,
NSCT.
After NSCT.
So that answer is very difficult, but yeah, it is to the tunes of 20 to 25%.
Because we have to
only.
tell the patient
Yeah.
that in about this much of amount we will be able to reach a surgical resection, and these patients will progress further. And in our practice in past 5, 6, 10 years, whenever it has started, we have not seen even a single patient who has gone for a chemotherapy for a borderline resectable pancreas, came back to us, and we resected it.
So I think, sir, 20 to 30% rate is still there, and happy to say that. And if they for some reason or another we are not surgically resectable, I think you can go for an completion of with the CTRT. So you can adjuvant with that as well. But yeah, upfront NACT, the conversion rate is not more than 20-30% in my real practice.
So the problem with CTRT and ACTRT is that the resection, usually these tumors are never downgraded locally. So the disease amount can be less, but the resection amount, if you will consider the venous and the arterial resection, if you are contemplating, then it becomes even difficult after radiation.
That
Not only in the chemotherapy though, but after CTRT, the resection becomes
I think if the tumor has not downsized, it's already telling you the biology of the tumor, it is going to be bad.
So no, I think
Yeah.
I'll take a stand to disagree on this point.
Mhm.
I don't think radiological downstaging is the aim of this game.
No.
The aim is to give the patient multimodality treatment, make sure the disease is not progressing. There are no adverse clinical or radiological prognostic factors that emerge during chemotherapy, and then give the patient a fair trial of resection if the patient is fit to be taken on table. A huge bunch of people in surgery medical oncology and radiology will agree that there is no true downstaging from a borderline resectable to resectable that will occur in a PDAC, or even from locally advanced to borderline resectable. Also, I think that the figure of 20 to 25%, maybe 10 to 15% going for resection is more true for locally advanced. Borderline resectable, I think 50 to 60% will come to table.
Well,
For
again,
at least
you know,
a trial, a fair trial.
at the end of the day, our goal is to get the surgery done, to be honest. We want our patients who are borderline resectable to convert them into resection. Or even if the patient is having a locally advanced, my main goal of the starting the treatment is to make sure that the patient should undergo the surgery. The goal is very simple. We have to have MDTs for every case, and that is the benefit of the institute. Where you have MDT, you can better predict those patients where NACT can be contemplated. NACT is not there to give you a cure of the disease. It is just there to give you just the shrinkage of the tumor where surgeons are better able to take the disease out. The goal is simple.
The main aim.
I agree with what Dr. Disha is saying.
Hmm.
My question was, how much is the number of patients, those who reach a surgical resection after, because NACT you give and you see them after 3-4 months time, and majority of them are advanced to a metastatic disease.
Sir, see, I think,
My question was specific.
again, I am giving very specific answer. If you ask the overall data, I think it is to the 20 to 30% where you can go for the resection. For me as an individual where we are practicing, if I have a patient out of 10 patients, I have been able to send only 2 patients back for the surgery. It is as simple as that. There is no confusion in this point. And even we tell the patient before they come to us, that is our job, that your possibility of landing up with the surgery is going to be this much %. If you find any surgeon who is willing to take the upfront surgery, we refer them to the surgeon itself.
So just one small note here. The decision to not operate should be after a surgical assessment by a surgeon, not by a medical oncologist or a radiation oncologist.
I don't think
with
any
or
medical
without
oncologist can say no to the surgery. No. We never do. We have a very harmonious relationship, don't worry.
Good to know that.
Yeah. Sir.
Aditya, is there a paper where on borderline pancreatic cancer gone for surgery and what is the
So,
2 years of
I didn't incorporate this into the slides, but yeah, the phase 2 trials and phase 3 trials are also there. We'll share with that with you. The data is there.
because what happens when the patient goes for chemotherapy, chemoradiotherapy or chemotherapy, then what happens if somebody, if the patient has got a poor tumor biology, and suppose if they have a metastatic disease while they are having, sometime is good you didn't do surgery.
Absolutely.
Yeah, rather than going and having a upfront surgery,
Yeah.
because that gives us time to assess the tumor biology also.
So, till today, we have given so many NACTs, and I'll be honest in saying that, and I think Dr. Sham sir, if he is here, no, he's not here. He will also agree to the point, while the patient is on NACT, I have not seen any patient progressing on NACT. I might have seen stable disease, might have seen 19 का 20 होना, but I have never seen a new lesion bone में आ गया, lung में आ गया, liver में और बढ़ गया. I don't want to see those cases, but yeah, data to say right now, NACT, the conversion rates is not more than 20 to 30%, and I will stick by that. In practice, it can vary. Institutional protocols vary, institutional thought process vary, and the oncologist who is giving the chemotherapy, it's his responsibility as well to maneuver the dosages and the protocol to make sure that the treatment discontinuation rates while on chemotherapy should be less. If the patient, we are able to fulfill all these data, I think 20-30% still has the chance to undergo the surgery. Thank you, sir.
Thank you. It was indeed a great discussion about all those borderline pancreatic tumors. We are a little delay because of the delay in flight of Dr. Shailesh in starting the panel, but in the meantime, he's just 10 minutes away from the venue. So I'll have a short 10 minutes video on our technique or a modified technique, how we do pancreaticojejunostomy. This was not in the program, but yes, in between fillers, I have to prepare because of the weather and other things. Sorry to bear with that, but this is going to be an interesting thing. So we started doing minimally invasive pancreatic surgery with Dr. Rawat leading us, and we started, when I was with him, we started this program, and then we progressed to doing it with partially lab, which we called as lab and robotic. We called it lab robotic assisted pancreaticoduodenectomy. So as you all know that the outcome of PJ remains the index of pancreaticoduodenectomy for pancreatic cancers, or in any other scenario where you are doing it, and PJ leak is a major problem, and this has led to several modification in the techniques. And yesterday I was discussing this with Dr. Arvind, and he was telling me that it is not fair to learn only one technique of doing an anastomosis. I don't know which will work for you when you're doing it on a regular basis, and ultimately we all adapt to our technique or do take some bits of modification in what we have learned from our masters to perform the pancreaticoduodenectomy and pancreaticojejunostomy. So the outcome factors are many. They are patient factors, which is for which condition you are doing the surgery, which is the head of the pancreas or concomitant pancreatitis, if it is there or not, the duct diameter and body mass index, the surgeon's factor. That's why we are discussing about it, the different ways of doing pancreaticojejunostomy, and the technique, whether it is mucosa, demucosa, or dunking, stenting, or non-stent. And the attempt to have a circumferential duct to mucosa suturing is challenging due to the posterior location of the duct. Many of times when you are have dissected the pancreas, you see it is eccentrically located. It is not located in the center. So this is a problem, and it is also in the vicinity of major vascular structures, which causes a little bleeding, and then you are a little tensed. Then this potentially leads to suturing very close to the margin of the pancreas, which can give way if there is soft pancreas. So with this background, we use selective ductal mucosa suturing with conventional dunking, which is the modified dunking technique, and this will be presented in the next videos. This is how we make the port positions in the abdomen, and you can see the camera, which is slightly on the right side. If you can see, yeah, slightly on the right side of the umbilicus. R1 and R2 are the robotic arms, which were initially the laparoscopic arm only, and A2 and A1 are the assistant arms. So as you all know that pancreaticoduodenectomy involves the resection of this part of the organ system, and after that you have such pancreas which is transected around the neck, and you put a jejunal loop around to create an anastomosis. So this is the first layer which we do. We do a 4-layer modified dunking technique. In this video, we are using the Da Vinci SI robot, which is still there in our hospital. We also have a Hugo Ras. Thanks to the management and Dr. Rawat for getting us the new robot. And here we are using a 4O PDS suture. So you can see the pancreas, which is there, and the jejunum. What we are doing is, the posterior most layer is to be done first, and we are starting with the anastomosis. These are all interrupted sutures. Sometimes during the surgery we face difficulty when you're taking sutures through the pancreas. They can get cut through because of the nature, how soft the pancreas is. So you have to be very gentle. Even if they get through, they also cause some bleeding because of some vessels which are running along parallel side or over both superior and inferior margins. You have to be careful for that. As in minimally invasive surgery, this is the hallmark. You cannot proceed if there is blood in the field. So your field should be as dry as possible, and you should any kind of blood, you have to control that bleeding so that you can proceed in your own way. Otherwise, the things go haphazard, then you have to either convert, and conversion is not a failure of laparoscopic surgery. This is what we have been taught. So any conversion is just for the safety of the patient, and which is the utmost final our motive for the patient. So like this, we have created first layer of anastomosis, and then we proceed with the second. The pancreas is now anchored at the posterior aspect, as you see over the right side diagram, and once we identify the duct, we make an enterotomy in the jejunum which is less than the overall diameter of the pancreas. Since jejunum is a muscular organ, when you try to anastomose, the small opening may become big later on while you're stretching and doing the anastomosis. So here you can see the first suture being going from within the pancreatic duct, the posterior aspect where it was eccentrically located, and through the layers of the jejunum where you have created the enterotomy. Similarly, another suture, we take it at the another margin as shown in the right side of the figure, and again you take the full and full thickness of the from outside to inside, same PDS suture. Initially we were not even stenting the anastomosis, but now we are stenting it routinely with a feeding tube or a salicylate tube. After these 2 or 3 sutures, we just don't take any sutures from the duct. What we do is, at the line of the duct, we take the sutures within that line only, taking the full thickness of the pancreas and just anastomosing it with the enterotomy which we have made. So as there is a fish mouth opening of the duct within the lumen, which we stent nowadays, and the whole of the pancreas is plastered to the enterotomy, the edge of the pancreas. And this is the cornermost suture. You take at least 5 to 6 sutures on the posterior aspect to complete this second layer of anastomosis. So as you can see in the diagram, there are 6 sutures, 2 from the duct and 2 from along the sides of the duct, which you have taken to complete the second layer. At the start of the third layer, you have already have a jejunum which is anchored to the pancreas with your previously taken suture. Now what you do is you just take the anterior portion of the pancreas and anastomosis just through the anatomy, just like you're forgetting the duct and doing some sort of plastering the cut edge of the pancreas to the enterotomy which you have made. This is simple as it is towards you, and you have already put a stent or done 2 layers previously. We use the same suture, 4O PDS. In case there is a bleeding vessel on the margins, you can take a little broader suture to control the bleeding, but I think 4O PDS is also sufficient enough to control the bleeding. So again we do about 4 to 6 to 8, whichever is there, 6 at least suture on the third layer, and plaster the pancreas or do the anastomosis as shown in this video. Sometimes if there is a softer pancreas, what we do is we can go from the jejunum side, take the pancreatic bite, don't take a knot on the pancreas, come back again and take the knot over the muscular jejunum, rather than taking the knot over the softer pancreas which can get cut through. The last layer is fairly simple, just like you override or take a dunking kind of thing which we do. That is the reason we call it as modified dunking. This is just overswing layer from the surface of the pancreas to the jejunum. This is also done in the same manner by 4O PDS suture. So in the end, the pancreas is anastomosed in a 4-layer fashion with minimal suture taken from within the duct, and just for the anchoring of the midpoint of the duct with a stent and a 4-layer anastomosis. So till date we have done around 60 or 65 such anastomosis. We also resort to other procedure, other techniques of anastomosis. It is rightly said, all the anastomosis at every aspect, same anastomotic technique may not be feasible in all patients. So we have to have a patient-centered or a scenario-centered approach in a particular case scenario, where you can modify your technique as per the need of that particular scenario, or the need of the creating a safe pancreatic to jejunal or pancreaticoenteric anastomosis. We will also see various other types of pancreaticoenteric anastomosis in later video session, which will be shown by people who are presenting Vipul's, Dr. Pradeep Jain and Dr. Arvind, and also we will have some discussion with the pioneers, other faculty members who are joining us soon, Dr. Shailesh, Dr. Adarsh Chaudhary, and then we proceed with the wet lab in the afternoon. So thank you. It is just thousands of candles can be lighted from a single candle, and the life of the candle will not be shortened. This is a message which I want to give, and this is what we have learned from our masters. Thank you. Dr. Vasu, the location? Get me my phone. If there are any questions, or we have esteemed faculty members from BL Kapoor, Dr. Diksha, Dr. Vagesh with us from GB Pant, and our own faculty, Dr. Rawat, Dr. Amitabh. हमारी entrance पे है ना, ठीक है. So I think Dr. Shailesh is just arrived inside hospital, and we'll just wait for 2-3 minutes for him to start his session. Yeah, please. So the results are here. We have a fairly good amount, good outcomes with this kind of anastomosis. Video. So we have few patients with type B leak, one patient with type C leak, and few subclinical leaks type A. But yes, the overall morbidity and mortality rate is fairly acceptable. We have only one 90 days mortality and one over the 90 days morbidity in terms of type C leaks. We have two patients where there were bleeds. One was reoperated, one was reoperated, one was stented because of PJ leaks. PJ leaks do happen, and yes, it will happen more if you do more. It's always said that a person who has not faced a complication has not done enough. But like I told you previously, we're not stenting it, and the turning point for me when I started stenting was when we had this PJ anastomotic bleed. Bleed in the post-operative period, and we lost one patient. So then we decided to stent, and with the grace of God, after that we didn't had any major episode of bleeding or readmissions after our anastomosis. And the shortest period of stay after this robotic pancreatic urinectomy we done is about 6 days. We discharged the patient on 6th day, and the shortest time to start the chemotherapy for our patient is 20 days. Short about 6 centimeter, 8 centimeter only, not much. So you just have to stent that area. We also take a stitch over the posterior aspect of the stent to the anastomotic side with absorbable suture. I welcome Dr. Shailesh. Sorry. No, it's okay. No, this was just a filler in between. This was just a filler in between we were using. So, where is my paper? So we'll just start in 2 minutes. I'll introduce everyone. So, I want everyone to welcome Dr. Shailesh. Yes, especially joined us. He's the chief in Tata Memorial for Pancreatic Surgeries. And yes, a very dear friend. He always supports our program and take it pain to start early in the morning and come here. And we always look for his contributions to our conferences. We were just talking on phone that 2 years back we had a very good discussion on pancreatic exocrine replacement therapy. We wanted to create some consensus over it, and we did create that, which changed the scenario. And I was very happy that it was being discussed the same topic twice on a national platform over the meeting, the pancreas, which the gastroenterology group held. So now it's a start of the panel. I think we are still waiting for Dr. Adarsh, but he will join later. And we have majority of the panelists for Dr. Shailesh Shikhande's panel. I would like to invite the panelists first and introduce sir later. So I request Dr. Sumitra Rawat to kindly come on the dais and be the panelist. Dr. Vagesh, Dr. Pradeep Jain, Dr. Diksha Kapoor, Dr. Amitabh, please join us. So all our panelists don't need any introduction, but I'll still introduce our panelist. Dr. Sumitra Rawat is the Honorary Treasurer and Joint Secretary of Sir Gangaram Hospital. He is the man behind, I already told you, we started the program and getting us a new robot and upgrading our building. So you can see a very new fancy oncology wing which has been recently started. So yeah, we'll have a tour of it after your lecture soon. Dr. Pradeep Jain needs no introduction. He is a famous GI surgeon. And Dr. Amitabh Yadav is a faculty with us. He's been guiding us. I've been working with him since 2006. Dr. Diksha is a senior consultant with BLK Max and under Dr. Deep Goyal, who is my mentor. And Dr. Vagesh is a senior consultant in GB Pant and doing a lot of pancreatic surgeries there. So before we move on to start the session, slide please, slide. So short story about Lydia Maria Adams DeWitt. Can you switch the slide please? So she is a less well-known American pathologist, but nonetheless fascinating figure in the history of pancreas. Her story is interesting because she was one of the few female medical researchers in the late 19th and early 20th century, at that time when women faced significant barriers to entering science and medicine. She was one very few women publishing scientific research at that time, and her work on the pancreas was published in medical journals, and she gained respect among her peers for her meticulous research. She did dissection of the pancreas of the cat and clearly revealing the ductal anatomy and its relationship with the venous system. So why I'm discussing this is because the most meticulous surgeon I know in my life is Dr. Shailesh for pancreas, and this is how we are now linked together, and I've seen him from so many years, and till date I know he is very meticulous and very passionate about whatever work he's doing, especially for pancreas, and he has inspired many lives and he's still inspiring. I welcome Dr. Shailesh to start his panel. Thank you.
Neeraj, thank you very much for an extremely kind but very embarrassing introduction, but thank you so much. It feels good to come in the morning, to leave very early, to see everyone, so many familiar faces, colleagues and friends. That's an intimidating panel, by the way, but that's very good. It also keeps me ready. So we will have a panel discussion for 40 minutes and try to discuss something on the pancreas. Is that your telephone, Neeraj? So PowerPoint presentations 2024 will be here somewhere. बंद करूँ ये? 2024. PowerPoint lectures 2024, and you will have Gangaram Pancreas meeting, and then we have the first case capsule. Brilliant. It needs to come there. Great. I won't be specifically taking names. I think people should just offer. Let's have 2 mics over there. They are working so that we can save time. I've got 2 cases, but let's see whether we finish 1 case, and if we do, then we will have a second case as well. 54-year-old lady, a diabetic, good performance status, previous hysterectomy done, presented to us in October 2021 with pain in the abdomen, recent worsening of diabetes, also loss of weight, and an ultrasound abdomen had suggested that there is a pancreas body mass with an atrophic pancreas distally. The serum CA 19-9 was over 1,000,
and the other blood parameters that we would normally do as baseline scans, hemoglobin, albumin, protein status, liver functions, transaminases, all essentially within normal limits. This is a CT scan. Would anyone like to just give I don't have movie clips on the console, but would anyone like to give a broad opinion as to what you see? It's the same patient. There are different cuts. It's body mass, and there are some cuts which are the triphasic cuts. Please, whatever. I just want, rather than I taking names, the best is that you all offer, and you all are experts in your own right.
So it's a contrast enhanced scan of the abdomen, likely a triple phase, axial images. There is a mass in the pancreatic body with distal atrophy.
Do we have a pointer? Do we have a pointer by any chance? Yeah. More than a cursor, if they have one, it will be good. So that for the younger members, we can always discuss. I can discuss a little bit as a moderator with them if they have one. चल रहा है? या नहीं चल रहा है? नहीं चल रहा है. Okay, you carry on.
So fairly large, encasing the splenic artery, abutting the celiac axis origin at the left lateral aspect, abutting the posterior wall of the stomach. And also, I have my doubts in this last image on the right, whether there is some abutment with the SMA.
Okay, fine. So I think the clarity that we have in this picture is that you can always check for a triphasic CT scan. That's something which we insist on always. It's not working. इसकी battery थोड़ी weak है. बीच-बीच में चल रहा है, बीच-बीच में काम नहीं कर रहा. So the long and short is that always insist on a triphasic CT scan. Look for a pancreas protocol, look for a venous phase, and look for an arterial phase. And all the critical structures in the region are obviously the SMA, the celiac axis, the superior mesenteric vein and the portal vein, and the splenic vein in this case. Any concerns about the splenic vein in this case?
I think we are not being able to see the splenic vein. This is just, we are seeing the cuff from where the splenic vein should arise and go to the left.
Yeah.
We are not being able to see
exactly. So it's slightly kind of, if you see the lesion, the hypoechoic lesion is almost at the junction of the splenic vein with the portal vein. So it's not exactly a teardrop, but it's a kind of a suggestion that there may be an involvement. Of course, if I were to show you the hole, then we would be able to see it. So the concern for me in this case would be that the splenic artery is taken flush. The celiac axis is also involved. Lower down below the takeoff of the splenic artery in the middle picture. The proximal common hepatic artery is also a source of concern for me. In the last picture, there is some stranding around the SMA on the left side, and the splenoportal junction may also be involved. These are the things that I know in this case. So this is what it was. Involvement just beyond the celiac axis with left gastric artery origin encased. Common hepatic artery and splenic artery encased, complete splenic vein encasement with portal vein abutment of less than 180 degrees on the left side. Would you classify this as a borderline resectable, or would you classify this as a locally advanced pancreatic cancer?
This will be classified as a locally advanced.
Okay. But there is this line of thinking that when it's a celiac axis, it can be considered as borderline resectable also, unlike the superior mesenteric artery, which is definitely locally advanced. Of course, the doubt has been raised by Dr. Kapoor about the possibility of superior mesenteric artery, and then it is locally advanced. So this is either an upper end borderline resectable, if not already locally advanced. Soumitra, any thoughts on this as of now?
No, I think what you have explained is absolutely right. So,
fine. So this is a mass, 5.4, 3.3 centimeter hypodense distal body and tail of the pancreas. I already discussed this with you, that again, when you see a patient of pancreas cancer in your clinic, please be sure that you clearly define it as resectable, borderline resectable, or locally advanced, some of which may yet become resectable with good surgery. This is something where in the last 10 years we have made a lot of progress. It was easy to put the last category as locally advanced unresectable, but now you will get 3, sometimes 4 patients out of 10 who will be locally advanced unresectable, who will become locally advanced resectable disease. So we have this case which is locally advanced, and for this patient, what would be your thought processes? What I've tried to highlight here is that I gave you the history that the patient is in a good performance status, the patient has a cancer, and the biomarker is also high. So I always tell people in your own clinic, think about A, B, and C. Do you use A, B, and C classification in your clinic when you evaluate a patient?
Yes, sir, same. It is like anatomical factors, biological, and that's when we use it. And
Do you use it in you? You don't. So would you just go mainly for the radiology part of it? Okay. So now this is a difference of opinion, which is something as a controversy, which I bring it out here to you. You can have lesions which are anatomically resectable in the hands of an excellent surgeon like this gentleman. But beyond being able to resect it very well, what we now know is that your CA19-9 is not a very specific and sensitive marker, but still the best marker available in pancreatic cancer in the absence of obstructive jaundice. So there are certain cutoffs. And would you use CA19-9 as a guide to decide who gets surgery first or who gets chemotherapy or radiotherapy first?
CA19.9 alone we don't use.
Correct.
But as a combination of with different factors, then we can.
Okay. So essentially,
and moreover, if the patient of this kind, like who's having very high CA19.9, we like to go for PET scan also, in particular these cases.
Sure.
Normally we don't.
Fair enough. So I think you are justified in doing a PET scan. Anybody else has a difference of opinion? Yes.
I think we use, if we are seeing these patients, we always take into account all these factors. If a patient is not ECOG grade to less than 2, so, and biological factors that your CA19-9 is more than 500, and this much amount of, so we will practically will go that it is maybe potentially resectable, not the completely short resectable.
Sure. So how would you tailor your treatment for this case? In this case, you know, as per the ABC, there is vessel contact. Your tumor marker is more than 500. Performance status is quite good. She's okay. She's 1. So patient is good. So, but tumor markers and radiology is not so nice.
So it is considering all these factors, we will probably not go for the upfront surgery in these patients.
Right.
We will likely to go ahead with some other treatments.
So this is what I'm trying to bring out with the discussion, that one surgeon would feel that no, if it is resectable and patient general condition is good, yes, he would do a PET scan. If there is no metastatic disease, he will ignore the CA19-9 in isolation and still offer surgery as an upfront surgery. But the other surgeon says that no, I think we want to consider something different in the beginning, and then we can think whether surgery is possible. Any thoughts, Dr. Diksha?
I think I'll go with Amitabh.
Okay.
The way, because eventually this guy would need a ramps.
Okay.
That is what it is.
Fine.
So you want to be sure. I think biological factor, as you get maturer in surgery,
yeah,
you know, more experience, you start giving importance to the biological factor.
Fine. So I think just to highlight that just recently in the last month and a half, my team has come up with 2 publications on CA19-9, one in classical pancreatic cancer and one in classical periampullary cancers. Now, periampullary cancers and CA19-9 is not exactly the focus of this case discussion, but that's published in Annals of Surgery, a series of 472 Whipple resections for periampullary cancers, and how a CA19-9 serial follow-up can help you to detect the recurrence of periampullary cancer earlier, how the CA19-9 can help you to start treatment earlier, and how the CA19-9 can help you to prolong life even after recurrence in periampullary tumors. That's what we published in Annals. And then my younger colleague, Dr. Manish Bhandare, has published in HPB on pancreatic ductal adenocarcinoma, that if the level is more than 1000, you really are in difficulties. But yes, if it is otherwise resectable and everything is fine, it's not that you deny surgery to patients. The discussion comes whether these patients need to be selected better after giving them chemo. So if there is response to chemo, then the indication for surgery and conviction for surgery is stronger. If the response to chemo is not so good, then it can be a challenge. Would the panel broadly agree with this thought process in your clinic?
Fully agree.
Okay, fine. So I think there is unanimity in this particular case. Exactly as you highlighted, you already have preempted that PET scan, everyone PET scan, or would someone say CT abdomen and HRCT thorax? Is that wrong? If I say I don't have a PET scan.
No, I think PET scan is having a very selective role in, as Dr. Jain told,
Yeah.
that there are only specific situation you want to do a PET.
Yeah.
Suppose a patient like this, if you want to rule out a distant metastasis,
Correct.
then only you do a PET, otherwise CT abdomen with thorax is
Any
complete.
difference of opinion? All cases a PET?
In this specific case, where there is a thin line between unresectable and locally advanced, within the locally advanced, unresectable and borderline resectable, you have a confusion. There is a high rate chance that in this there will be metastasis. So PET scan in this specific case definitely will go for.
And which are the other cases where you will definitely do apart from this case? Again, for the members in the audience, for them to know that when would you do CT abdomen, CT thorax, and when would you do a PET scan? One is this case.
Yes.
Any other specific situations any of the experts would like to opine? Yes.
If suppose that the tumor size is very big
Mm-hmm.
and there are large, big lymph nodes necrosis.
Okay.
These are the patients who like to go PET.
Where you would again like to. So your suspicion for metastatic disease is higher. So the minute your suspicion for metastatic disease is higher, and if it's feasible, possible, financially and available, then you would not hesitate to do a PET scan. Is that what you all would agree?
Again, the CA 99
Is going to guide you. So suspicion. So look at ABC. I have highlighted to you that in pancreatic cancer, especially in borderline resectable disease and locally advanced disease, please look at ABC. That will help you to select and triage your patients better to maximize the outcomes in all the three categories of pancreatic cancer that we all will see. Staging laparoscopy. PET scan done.
Must.
PET scan shows localized disease.
Must. In fact, in any carcinoma of pancreas, even if it is resectable, staging laparoscopy is must, because even the literature says that 15% of patients we may.
If you are
alter for-
anyway going to be offering a palliative bypass, would you still do a staging lap?
Yes.
You
All
would do-
patients of GI cancers, in fact,
Huh.
including pancreas, do staging laparoscopy, because in many patients you alter the program.
Okay.
In fact, literature says 15%, but in my practice, I see 25% of the patients with pancreas cancer.
You will
they
detect a
have very
metastatic
small
disease.
liver mets.
Okay.
And we just take the biopsy and send for frozen section and reject the patient.
So you mean your CT abdomen, CT thorax and PET scan are all favoring localized disease, and then finally your staging laparoscopy is helping
Definitely, because
selecting
these are
out.
the modalities which are not going to pick more than 5 millimeter of, they
Fine.
can pick disease more than 5
So another
millimeter.
important point
Smaller
to
will
know.
not.
Fine.
I think body and tail, definitely laparoscopy,
Okay.
staging laparoscopy. But as you said, if you are going to go for a bypass
Yeah.
in a head, you can, go.
Fine. So you will be a little bit more selective. What about you, Dr. Diksha?
So for this patient, definitely staging laparoscopy before definitive resection. For large pancreatic body and tail tumors, yes.
Okay.
For pancreatic head, selectively.
Fine. In this case, is an EUS required?
No, about the staging laparoscopy.
Sorry.
So
Yeah.
a patient like this, which you presented,
Yeah.
we will like to do a staging lab, but where we are having a doubtful diagnosis whether it is a metastatic disease or not, even if PET is showing that it is not a metastatic disease. But routinely we don't because in Advent where we are having a very good CT scans and very good radiologists with us, so we usually don't consider doing a diagnostic laparoscopy essential.
Okay.
Before
A staging laparoscopy essentially.
except that
Yeah.
body and tail.
Fine. What about the role of EUS in this case?
EUS guided biopsy.
EUS guided. Why can't I do a transcutaneous? EUS is more expensive. Needles are, they can easily break. They are more expensive. It's a lot of business, you know.
The tumor is sitting
Endoscopists
just there.
enjoy life, but somebody has to pay for it. Are you an endoscopist? You two are looking at each other. Really? Okay.
The chances of seedings, the chances of seedings is much more with the percutaneous.
So is an
And overall-
FNAC also at risk of seeding? FNAC?
Yes, we think
CT
so.
guided FNAC
Yes.
also. Okay. So this has been shown by Andrew Warshaw way back in 1980 that a transcutaneous attempt is always going to increase the risk of seeding. So if you are looking at a potential resection, there must be EUS guided biopsy, which is safer and in interest of the patient. So I think from what I hear from them, they are looking at surgery or treating this patient with an intent to give a chance of a resection. Does everyone agree, or would someone say, enough, I don't want to do, we should just palliate this patient, it's advanced disease? All of you are surgeons and all of you want to treat this patient with a curative intent at this stage or palliative intent? Curative,
No.
curative.
Curative intent, but I like to go ahead with neoadjuvant treatment first, then.
Fine. So the important thing is that if I were to do this panel discussion 10 years ago, perhaps majority of the panel would have said that the intent is not curative. That's the message that I wish to highlight very clearly here, that there is unanimity. There might be some differences of approach in terms of PET scan, etc. But I think they all agree that curative intent. Neoadjuvant, surgery, what's the, at this stage, we will discuss, of course.
Neoadjuvant.
NSCT? Okay, fine. So this was the report. EUS FNAB was an adenocarcinoma. Is upfront surgery an option? They've already answered it. The intent of treatment we have discussed. Now, in neoadjuvant, let's focus on point number 2. Chemotherapy only, chemotherapy or radiotherapy?
NSCT only.
Only NSCT.
No radiotherapy.
NACT only.
Chemo only.
I think I will discuss in the tumor board and let it.
Now that's a leader talking, you know, that's classic Soumitra, but I know this. How many radiation oncologists in this crowd? Don't worry, madam. There are cases where we work very closely with you, don't worry. Okay. How many endoscopists in this crowd? Okay. They're going to kill me. Fine. Then
Totally accept with sir, tumor board discussion. It is left to the...
So one is tumor board, but now let's talk a little bit more about the science part of it. That when would you think that you need to perhaps consider radiotherapy? Because the other three have said chemo, they are clear. You two are a little bit more circumspect, which is fine, but why are you circumspect? There must be your own reasons for chemo plus minus radio. We will of course allow madam also to opine.
We are not venturing into the decision making into chemo.
Yeah, but hello, you are a surgeon. I want you to decide in the tumor board.
Neoadjuvant chemotherapy, our suggestion is, but ultimate decision is by the...
Okay, fine. So then, madam, when would you add radiotherapy in this case, which you have seen before, if I were to ask you?
The high dose per fraction has showing good results. Like
Yeah.
the comparison is that surgery alone with these borderline cases with chemo plus radiation. See, the cure rates are 20% versus 6% in surgery alone.
Okay, fine. So I think I hear you, and we will discuss a little bit about this. That these are the two options that we had in this case in our tumor board. One is chemotherapy, and the other is sometimes in some cases we would choose to add radiotherapy as a part of our case to case. I think I can stop talking. There is one gentleman very quietly slipping inside. He's delayed, but please come here on the panel. I thought I read your name here. You are called someone, Dr. Chowdhury, no? You are? Please come, sir. No, I took that chance to immediately embarrass you, but please come, please come. I see Shyam Agarwal sir also. Good morning, sir. How are you? Great. So I'll just quickly take you for one picture for you to broadly tell you this is the case. It's a body tumor. CA19-9 is high. Patient is in good performance status. There is some stranding around the SMA, but the celiac axis is the problem. Splenic artery origin is also gone, and the proximal part of common hepatic is also gone. Patient is well preserved, but there is also a vein involvement towards the left side, 180 degrees less splenoportal junction. So we have concluded that this is a locally advanced cancer. We have confirmed by US biopsy. We've taken the audience through the discussion about ABC classification. And we have said that perhaps PET scan in selected cases is good. Laparoscopy is also done selectively, but more often done by the gentleman on your left. And then we decided neoadjuvant therapy. And neoadjuvant, we discussed about chemotherapy plus minus radiotherapy. And this was discussed in our pancreas clinic. And then these were the options that we thought are available for this patient, including the last option, that is irreversible electroporation. I won't take it further because just now the intent of the panel is to go ahead with curative surgery if there is a chance after neoadjuvant therapy. That is more of a palliative option in case surgery is not possible. In some cases, some information is getting accumulated. So why neoadjuvant therapy? These are very standard theoretical discussions. I won't spend much time. You perhaps biologically select patients better. You will be able to downstage tumor. I think we have evidence that neoadjuvant therapy downstages, not necessarily downsizes. There is a difference about tumor shrinking versus tumor not shrinking, but tumor cells dying versus being active. That can be shown very well in a number of PET scans as well as the pathology reports if we do a resection in that. Also, you can start the systemic therapy. Patient compliance can also be better, that they are more committed to start treatment early rather than get a morbid surgery first where there is a 30% chance of complications. And then those 30% patients are likely to run the risk of delayed administration of adjuvant chemotherapy. So these are some of the usual reasons why we would look at neoadjuvant therapy in the case discussed. We also know that even with smaller tumors, if you do an operation, the pathology reporting shows that you have R1 rates which are 57 to 60% at Tata. That figure goes to about 70-75% elsewhere also for pure pancreatic ductal adenocarcinoma. But even smaller tumors like ampullary tumors, which are much better biologically, we would always want to offer surgery first, which is what we do. Our pathologists will say in 7 cases out of 100 that it is still R1. So we think we have done a good job, and this is what surgeons must realize, that there is more to these tumors than just doing a technically good job. So we have a problem of margin positive resections. This is a trial which madam would not appreciate. This came from MD Anderson. There are some problems with the design of this trial, but would anyone like to comment on this alliance trial by Matthew Katz? It was a trial which compared FOLFIRINOX and radiotherapy. And what they saw was that the FOLFIRINOX arm only, that is arm A, did much better. And actually the radiotherapy arm did not do much better. And this was done in MD, and she's waiting to hold on to the mic. Please go on, madam. We want to hear you.
Fraction.
Yeah.
Because they have given here in a
Correct.
conventional fractionation.
Correct. You're
So
right.
That may be the reason.
Yeah.
Because we have a trial going on with high dose per fraction. We
Yeah.
have to wait for that trial.
Yeah. So I think the jury is out. The only point I wish to highlight is in standard answer is neoadjuvant therapy. But in selected cases, would you add radiotherapy? You have not been asked this question because, you came late and disturbed us. So then now we ask you.
I thought you were already disturbed. Most cases, no, but if somebody doesn't respond to chemotherapy, I might add radiation, but not as a first choice.
Okay. So in case they respond to chemotherapy, would you add?
I don't add.
You don't add.
And I even think the data is also very soft to add it.
Okay. So I think the message here is that we need more data. We don't know as yet. And as of now, what we know is that if chemotherapy is working well, we are fine. But I think what madam says is also right, that more precise, higher dose radiotherapy will also help. Any other difference of opinion?
No, I think
all fine. So everyone agrees. So what did we do? This is what we did. Now madam will be a little happy. But this is what we did in this case, that we gave 12 cycles of modified FOLFIRINOX, and we also gave SBRT with our radiotherapy team. How would you monitor the response of your patient? If this was your patient, how would you, strategize the treatment? Anyone.
Shailesh, we all know that it's very difficult to see regression radiologically. I will go by CA19-9 on the performance status.
Fine.
There's nothing else, I think, because RECIST criteria occur for other cancers. For pancreatic cancer, radiological response is very difficult.
Correct.
And so difficult to differentiate scar tissue, malignancy response.
Correct.
So if performance is good, CA90- is good, I'll try to operate this patient.
Brilliant. So how early or how frequently would you reassess them? Because you will be working with your medical oncology and radiation oncology colleagues. So you will assess them after 6 weeks. So how many cycles?
After 4 cycles.
Four cycles
each time.
And then after 4, if the response is good, why would you not go ahead and operate?
My argument is this, that I generally believe it's not based on science, that I want to finish all my chemotherapy before surgery. Because this disease, you operate, they have wound infection, they have complications, subsequent chemotherapy gets delayed. That's my argument.
Okay. So you would prefer to give, after 4, if everything is good, add some 4 more and see again.
But Mike, can I ask you a question? Suppose after 4 there is no regression. Then what do we do next?
So the regression in terms of CA19-9,
Yeah.
so instead of that 1000 becomes 900 or becomes 1100, and the patient is not feeling so good.
The patient is feeling good.
Good.
Yeah.
But the tumor marker did not respond.
So choice is add another chemotherapy or add radiation.
So now I know Shyam Agarwal sir is sitting there and we'll bother him, but I can, since you asked me the question, if we have started off on modified FOLFIRINOX, there are occasions when we would actually change it to gem-nab-paclitaxel. But of course, I have to discuss it with my medical oncologist. I know that precision oncology doesn't help much in pancreas cancer, and definitely not in an intent where the intent is curative. We would look for next generation sequencing, etc., but not at this stage. So we might just change it to gem-nab-paclitaxel is what we would do. Your thoughts? Fair enough. This is also a fair
Right.
because
it's a very soft kind of situation there. but
situation.
then, yeah.
So if
If
1000
is rising,
yeah,
and the patient possibly has some pain, well then I think we are obligated.
so suppose it is 1000 at baseline and it becomes 1300. Patient is okay, but not necessarily much better. He's okay. He's neutral about it. हाँ ठीक था कीमो के पहले भी अभी भी ठीक लग रहा है लेकिन ये रिपोर्ट सही नहीं है. How would you handle it? It's a practical situation which I do face also. I'm sure we all, everyone's nodding. All, sir, you have to help them. You have to tell them what to do.
So after the first 4 cycles of FOLFIRINOX, about 2/3 patients will see a jump in CA19-9 to the tune of 15 to 20%. So not everybody will agree that that's poor biological response. It's
The
physiological.
initial jump, you mean?
It will increase. The CA19-9 will increase.
Okay. It's showing stable. Scan is stable actually.
I don't mind giving another 2 cycles.
Okay, fine. So now this is the other point that I wish to highlight, that the conventional approach would be 4 and reassess and another 4 and reassess. But you will always get these variations and then you may have to call back in 2 cycles because you have hit a roadblock. You're not really on the right path. If you are on the right path, that 1000 has become 600, patient is feeling fine, CT scan is stable, you will say just take 4 and then come back again. But otherwise sometimes you will have to give a couple of them more, be a little bit more unsure with the patient, document that there is an uncertain prognosis going ahead, and then you will see. Fine. So 4 and 4, 8, or what is yours? You are also total neoadjuvant or operate after 4? Total neoadjuvant. Okay. Total neoadjuvant. Total neoadjuvant. All complete. Am I wrong if I operate on this patient after 8 cycles and maybe add SBRT and then operate after 8 cycles or 10 cycles and not complete total neoadjuvant? Am I wrong?
Most
Fine.
have the sandwich.
Yeah.
So they would do, few cycles initially, then operate, and then complete the chemo. I mean, most of the trials are done in that direction.
Yeah, but I think surgeons are also acknowledging the fact that when you have a complex operation, at least 20 to 30% patients are going to get morbidity, which will delay the remaining adjuvant chemotherapy. So I think for these advanced cases, even we would prefer that let surgery be sequenced last rather than trying to come in between.
Shailesh, it's also important how the patient is behaving.
Yes.
In my practice, 50-60% patients do not reach a full course.
Okay.
They raise their hands, we cannot take more than this. So we are forced to operate them.
Okay.
Because it's very toxic.
Okay.
And we are great students of sarcopenia, we oversee these things. And they get very sick.
Ah.
And I'm scared they might never reach surgery.
Mhm.
So in some cases, I may have to operate early,
Fine.
but I prefer, if possible, patient is fit, operate. But I agree with you, that's no data on that.
Fine. So I think total neoadjuvant therapy has been very much around, and one of the most aggressive surgeons in the world, Mark Truty from Mayo Clinic, has published this in Annals of total neoadjuvant. It's retrospective, but I think somebody who's actually doing these surgeries in very large numbers, vein and artery resections, reconstructions, he's justified in presenting retrospective data. Where they have done total neoadjuvant and then operated with much better results. So that's one thought. Most of the trials are having this perioperative chemotherapy concept, which is what we would also largely do in our practice at Tata Memorial, and we have a large experience on the same. But there are some cases, like in this case, where we have done total neoadjuvant therapy. Madam, a word about SBRT from you. What we realize is that we normally give about 8 cycles in such cases, and then after these 8 cycles we bring in SBRT. We discuss with our radiation oncologists in this particular case, the reason we got SBRT is because of the contact with the artery more than the vein, because we are looking at not just a RAMS but an Appleby in terms of a celiac axis resection, plus a concern around the left border of the SMA as regards the stranding. So I have thought of adding radiotherapy to sterilize the margin. Would any one of you, despite the total neoadjuvant chemotherapy approach, want to consider radiotherapy in these areas, or you would not? Have you had bad experiences? Have you had no experience, or you rather not, because there is no evidence, which is all respected. All statements would be respected.
Depends on the response scans. How
Response is good. Things are looking good.
if I feel it can be done safely, I would avoid radiation.
Okay,
So
fine.
I would also not like to add radiation
Fine.
to the, because post radiation you have to resect so many, you have to work on a central system.
Fine.
So the chances of intraoperative mishaps are more.
Okay, fine. Okay. So no radiotherapy. Okay, fine. So this is what we did. You have a comment?
No, usually now what we have experienced till now is that old method. Now we can give differential doses to the artery and the vein and to the primary tumor. So we know the extent of dose we can give them. I don't know. I mean, surgeon will be able to tell us once we have done it how difficult or easy to do after these newer techniques of radiation therapy.
Fine.
So I think
Fair enough. So that's what I spoke to you here, that we gave modified FOLFIRINOX. How do we sequence the therapy? We look at radiology, biology, and performance status. If the ECOG is good, there is a drop in CA19-9, we are okay as long as there is no metastatic disease, no local disease progression. But it's relatively insensitive to assess resectability. Many of these patients would require a formal exploration to assess whether you can take it out or not. Would you agree with that beyond radiology? Fine, fine. So I think some of these cases you can't predict resectability easily only on the CT scan unless there is a marked regression, which also happens occasionally but not routinely. So this was the response assessment on CT scan after total neoadjuvant. Stable disease, no great shakes. Patient doing fine, but you can still see the bulkiness of the disease going towards the retroperitoneum, towards the gerotas, to the left of the SMA, as well as involving the celiac axis and the proximal hepatic. But now look at this, the CA19-9, 18.89, patient absolutely fine, walking into the hospital absolutely fine. You will not think this is pancreatic cancer. Nutrition ongoing, good physiotherapy, very acceptable lab parameters. This is what we have done. We have done a staging lab. We have done an anterior RAMS, but we have done type 1 portal vein resection, predicted 180-degree contact at the junction of the splenoportal confluence. We did a celiac axis resection beyond the origin of the left gastric in an effort to preserve the left gastric also, but you can sacrifice it. But beware as to how much stomach you want to preserve or otherwise. I burnt my fingers once 3 years ago, but it's once. But that one episode was also a very difficult episode to handle. So you can have problems with the celiac axis resection with the stomach when your focus is only on gastric cancer surgery. You know about which patient I'm referring to. So left gastric artery divestment was done in this case. And then we have done a common hepatic artery end-to-end reconstruction. So this is what the picture is, that the blue portal vein, you can see that the stomach is well preserved. Cut end of the pancreas is then sutured. It's a subtotal pancreatectomy. Type 1 portal vein resection. The common hepatic artery is reconstructed by harvesting a splenic artery from the resected specimen distally. And the thinned out left gastric artery is because of the divestment where we have done subadventitial dissection. We sent that for frozen section, that was clean. So many a times I want the young surgeons to know that the celiac axis may not have the origin of all the blood vessels at the same level. You have just a little bit space where the left gastric is originating a millimeter or two earlier than the common hepatic and the splenic, and that's what you see here, that we could resect the splenic completely flush. We could resect the common hepatic with a stump and put a splenic artery graft, and we could safeguard the left gastric, and then we could do a ramps on the left side. So this is the histopathology of this patient. Once again telling us that we have made progress with chemotherapy, and actually that should encourage surgeons to do more surgery. So just because chemotherapy has got better and radiotherapy is also getting more refined, it doesn't undermine the role of a surgeon. In fact, there is a so-called renaissance of more aggressive surgery because we have got other areas in pancreatic cancer management coming up. So would you agree that you are now more motivated for more aggressive surgery or not really for pancreatic cancer?
People like you are making us do that.
Fine, but I think we have results, and I think you will always be doing sometimes more surgery than before. So the message I want to give is that the medical oncologist or the radiation oncologist is not saying don't do surgery. They are saying that you select out cases better and do even better surgery because we've got better products with us. And I think that is resulting in a nice group of patients who can benefit much more. Now we are done total.
Just a small question.
Sure.
Suppose your GDA is okay.
Suppose
your GDA is okay.
Yeah.
Do you still require a reconstruction of CH?
So I tell you what, ideally when you have a good Doppler in place, which you should have in these cases, and you can document the right and left hepatic artery flow with a good probe and a GDA flow and the right gastric flow, in a well-selected patient, the right gastroepiploic and the right gastric and the liver are all safe, and you can do a modified Appleby where you just clip off the common hepatic, leave the GDA intact, and you are fine. And we do that also in a number of cases. But I've had one case, perhaps it's a selection problem, that he was a diabetic, a heavy diabetic, uncontrolled. He did not respond well to chemoradiotherapy, which is what we discovered on final histopathology. The response was florid disease. My pathologist calling me after 8 days that there is hardly any response to chemoradio. We reconstructed we resected the left gastric in this case, but we reconstructed the hepatic artery in this case, only for the liver because he had received a lot of chemotherapy also. So sometimes I'm also making sure that the GDA is not doing too many roles at the same time. Take care of the liver, take care of the stomach. I don't know whether this theory is right, but 2 months later he developed a fundic ulcer of 5 centimeters. And he died of complications of a perforated gastric ulcer. But he was a diabetic, he was advanced pancreatic cancer, he was not detected with pancreatic cancer despite being a doctor himself for 9 to 10 months. So he got therapy from an orthopedic surgeon for treatment for back pain. So this can happen. But that day I realized that yes, they say 37% patients get gastric ischemia. So I am now doing two things, either doing something like this or adding a subtotal gastrectomy. No headache. I don't want a second innings in these cases, and it's easy. It's easy to do a total gastrectomy also. It's very easy to do that operation at the primary intent. Sounds horrible, subtotal pancreatectomy with total gastrectomy. But if you really get an R0, they still have a good quality of life. That's not a problem. So I'm careful about this.
Main concern is more of arterial reconstruction you do, the more chance of complications.
You are right. But a single arterial reconstruction with a safe pancreatic closure under vision is not a major problem. One arterial resect. Now, if you can completely avoid it and also have no morbidity on the stomach, do it by all means, and we do it also. So I think it's on a case-to-case basis where you will have to take a decision on the table. So I counsel my patients for all eventualities: a total pancreatectomy, an arterial reconstruction, non-arterial reconstruction, subtotal gastrectomy, total gastrectomy for these kinds of cases. Because you may change your decision on the operation table based on how things are. Any role for adjuvant treatment now? Total neoadjuvant done, patient doing fine. Radiology, pathology says good response. Any role for some more chemo? Chemo has done well for this patient. CA19-9 has come down. You have done great surgery.
A difficult question in this setup.
Yeah.
But definitely if total neoadjuvant has taken care of and your biopsy shows this picture, I will just like to follow it. 3 months interval.
They too will take it to the tumor board. You three?
I will give it.
You will give it? Follow up. So 2 people not giving, 1 is giving, 3 not giving, okay, and 2 tumor board. Agarwal sir, they have taken the case to you.
No, we got a great team.
I know this.
And they know what is the latest paper which has come.
Pancreaticcancerindia.org was launched when he came to Tata and he came to Tata. Myself and the current director of Tata, Sudeep Gupta, we were working together in the same group. Sorry, you were saying something.
I think if you send it to him, definitely get it.
Sir, but after total neoadjuvant, this kind of a path response, any role for adjuvant? What is the evidence, or should we still treat it as occult metastatic
so I think we
disease?
need to get this straight. So which is what I'm going to tell in my presentation, but now that you put it here. So why are we talking about chemotherapy so much? It's just because after surgery, 90-95% patients relapse.
Yeah.
And it's systemic.
Yeah,
Prodige trial clearly showed that, the clear fall
so
off.
we are looking at a disease which is so bad.
Good.
In terms of
And Sham, we've only taken care of local disease.
you've given you've
Sir,
given the FOLFIRINOX, which is good enough.
Sorry,
But
I'm
then,
preempting your talk maybe, but this is what is
that's
a part
okay,
of
that's
this
fine.
presentation, that FOLFIRINOX showed clear survival over gemcitabine, randomized trial.
That's all I was going to show. But
And
then
these are the
but
two
you already
good
given
lessons.
FOLFIRINOX.
Yeah.
So the issue is, do we supplement it with further, say, gemcitabine, or that's the only drug left.
Yeah.
But,
But would we not give FOLFIRINOX again? If 12 are done, another couple of
data
them?
beyond 6, sir. No cycles, no.
No
I would
data.
like to change
Okay.
if you were to give me
Fine.
that.
That's another message. But I think that second message is that even after apparently successful surgery, there is an early fall off in survival due to death from disease progression in patients treated with upfront. Of course, we are giving neoadjuvant, so we can't extrapolate, but the philosophy is at least take it to the tumor board and then take a call. Fine. Okay, I think I stop, and we will be very happy to discuss afterwards. Thank you very much for your active participation. I have to join the panel? ये निकालोगे?
Thank you, panelists. And I request, we're running a little short of time, but yes, we'll catch up. I request Dr. Adarsh Chaudhary and Dr. Shailesh to be on the panel for the next Dr. Shyam Agrawal's. So I request the panelists, Dr. Deep Goyal, Dr. Shikha Haldar, Dr. Sushant Mittal, who is a dear friend, to kindly come on the panel. Before I introduce our moderator, Dr. Shyam.
So
things have been said.
एक सेकंड हाँ ठीक है सर आप स्टार्ट करें प्लीज
So good morning, everyone. I think most of the things have already been said and discussed at a reasonable length. So I divided my discussion into 3 or 4 parts. One was the adjuvant, the second was neoadjuvant, then borderline resectable or advanced, and then of course metastatic. But then I think a lot of things have been covered by Shailesh and in the previous discussion. So I think this is what I was referring to, that the problem is that 95% of patients recur after surgery alone, and therefore this is considered to be a systemic disease, and that is why there is so much of focus on adjuvant chemotherapy or neoadjuvant therapies, so as to eliminate the microscopic disease, which is the reason why patients fail after successful surgery. And so this brings us to the point of adjuvant chemo. Let's begin with that, because that's where Shailesh left, that what is the role of adjuvant chemotherapy. And so if you have a patient who's been operated for pancreatic cancer, Dr. Sushant is there. So what do you think, currently your practice at this point in time for a resectable pancreatic adenocarcinoma?
So surgery has been done.
Yeah, surgery has been done. So I think let's cover that issue. Do chemotherapy, do you think of radiation, do you think of combination?
Sir, chemotherapy, radiation is only.
We'll come to that. So since you are a chemotherapist, so you have to, for the benefit of the audience, tell as to what chemotherapy protocol are you offering today for your patients who are resected?
Gemcitabine based chemotherapy or FOLFIRINOX, depending on the performance status of the patient, the albumin status, the age and everything. On that it depends.
So when you say gemcitabine based chemotherapy, what do you mean?
So gemcitabine.
Gemnab?
Gemnab.
So I don't know if there's any other chemotherapist in the audience. Do we have evidence for Gemnab in adjuvant setting? Anybody? Or I'll just show you a slide there. So I think this is how the adjuvant chemotherapy has evolved. That is from Conco 001, where gemcitabine was shown to be superior to placebo. And then, 5FU was also better. But then this SPAC study has shown GemCap as the standard of care for patients who are considered to be not perhaps fit for FOLFIRINOX. So those are the two regimens to my mind at this point in time, which are, prime time use. So most of the patients actually, when they come to us, they are not good after the surgery and they are perhaps elderly. So I think this is the go-to regimen, the GemCap, which is I think 80-90% in my practice. So is that true? You agree, Sushant?
Yes, sir, I would agree with that. GemCap is also one of the regimens which commonly we use, sir.
Right. So this was which?
Is it because of the better tolerability?
Yes. Yes. So FOLFIRINOX is a a kind of a little toxic and a dreadful kind of a regimen where you have a lot of side effects. So this is what Dr. Shailesh was showing us, the Prodige 24 adjuvant study where FOLFIRINOX modified was compared with gemcitabine, and you can see the curves in favor of FOLFIRINOX in the adjuvant setting. So if you're a fit young patient, 40, 45 years, so I think this is one which we should be preferring over gemcitabine. Then of course, so this is the negative study. So which people wanted to, because NAMPACLI GEM is the metastatic malignancy protocol which we offer in our day-to-day practice, and this was compared with gemcitabine. Unfortunately, this did not show the positive outcome, and therefore you have those two regimens, GemCap and the FOLFIRINOX. Okay, so I think this is the APACT adjuvant study. So now coming to the radiation, Dr. Shikha, do you want the surgeons or the chemotherapists to send patients to you after they have done the R0 resection?
Definitely, if margins are positive or lymph nodes are positive, yes, I would like to add local radiation. I know the historical data does not show any overall survival difference, but there is definitely a local control is better with adding of radiation therapies. And as I have been mentioning, so it is a dose per fraction which used to be used is at fault, I feel, with newer techniques. And we are
so how many days radiation will you give, when at the what dose?
Earlier it used to be 20-25 days, like 50 gray in 25 to 28
the conventional
fractions.
regimen, yeah.
Yes, now it is like 30 37 gray in 15 fractions.
Okay, so this is the study.
4.5 fractions per, for 4.5 gray per fraction into 15 fractions.
So do the surgeons agree to this? Because this is a recent study published from ASCO where they showed actually DFS and OS benefit for radiation in node negative patients. Right. So there's a controversy because she said you like to do for node positive. So Shailesh is nodding his head. So I think we have to keep, I think we've not been referring so far for radiation, but I think based on this data, Dr. Shailesh, you want to make a comment? Yeah.
Yeah, I said.
Node positive disease. This is essentially a systemic problem. So the minute you have anything more than N1, which are node positive disease, we are
Still, sir, even this ASCO guidelines, they are saying ki node positive to consider radiation therapy because there is a higher chance of local recurrence.
Shailesh, same analogy from CS stomach. Node negative, you also choose radiation. Only if margin positive. So node negative, margin positive for CS stomach means
node positivity, margin negative, still there is a road of radiation.
no, not in stomach. It's still flot.
If the surgery has been adequately done.
If you have done radical D2 gastrectomy, McDonald's is long over.
Yeah.
So flot 4 cycles before radical surgery, D2 gastrectomy, standardized, reported, done, harvested nodes, path reporting, and then further 4 cycles of flot is what we would do standard. No radiotherapy, no.
So, sir.
Yeah, right. So I think the conventional thinking was that if the nodes are positive, patient has a high tumor burden, so your adequate surgery and adjuvant chemotherapy may not be able to, sterilize the patient, and therefore, in order to sterilize the disease, you can come up with radiation, as Dr. Shikha is suggesting. But I think the evidence is to the contrary. Dr. Sushant.
Do you ever take the patient who is margin positive for revision of the surgery? Is there anything? But not in pancreas.
Yeah, and this is also theoretical because how many cases you will get which is a duodenal margin positive with all nodes negative, where the margin on frozen section was also reported as negative. So this is a more of a theoretical discussion. Practically speaking, very less, even in stomach.
So yeah, these are radical surgeries, and repeat surgery is not easy to perform, especially. Dr. Chintamani, you wanted to ask something?
No, I was referring to the earlier discussion that node positivity essentially means systemic disease now.
Right.
A lot of times when radiation is also for the loco-regional control like surgery. So earlier the thought was that if it's a node positive disease, it's locally a lot of tissue that you need to sterilize. So I was going to say the same thing.
But I think based on the data which we just showed from ASCO 2024.
Node negative is where the radiation is indicated.
Right.
And so the second one that you're referring to, one, the redo is not easy.
Yeah.
Two, most of these patients by that time, they're not fit enough for a haircut also. So it won't make great sense to do it.
Right. Yeah, but I think this is a take-home message that patients who are node negative, we should not only give them adjuvant chemo, should also contemplate doing radiation, which I think we have not been doing until so far. So I think this is because of recent data. So now, since the focus is on chemotherapy, focus is on systemic disease, so like Dr. Shailesh said, showed the previous case, but in a resectable pancreatic cancer. So Dr. Deep, will you refer the patient for, resectable? This is, upfront resectable. Would you refer the patient for neoadjuvant chemotherapy? Do we have the data?
Yeah, so when we say
use the mic.
When we say resectable, it's on imaging. We have to see what's the biological marker. If CA 19.9 is high, I will definitely like to maybe do a PET CT and quantify, and then I will err more towards doing a neoadjuvant treatment, even in resectable tumor, if CA 19.9 is high. If CA 19.9 is high, good performance status, I may straight away go for surgery.
Do surgeons agree? I mean, would they refer page? No, so they are shaking heads. So, so do we have the data there? I mean, to support Dr. Deep's conviction in chemotherapy, physician.
CA 19.9 is such a non-specific thing. Just based on that, you cannot decide what kind of behavior.
CA 19.9 and a PET CT.
No. PET CT is okay. CA 19.9 can be high, but patient is resectable. No NACT.
So if
well, I don't think there is a.
if it's a large tumor, nodes are seen, and there is a possibility of doing a vein resection, requiring a vein resection, even in a resectable pancreatic cancer, I think there's no harm. It makes sense to give 4 cycles of neoadjuvant and then reassessing.
So I think what she's trying to highlight is that she's actually referring to a resectable disease which is going on to borderline.
Borderline resectable, right.
But I think your question in
Yes.
primary was that a pure, simple resectable lesion.
Correct.
So I think we have to factor in the fact that perhaps about 30% of patients there might be progression because we still are struggling for better chemotherapy. In the sense we have made great progress, sir will agree, with FOLFIRINOX, but FOLFIRINOX is old chemotherapy which is working well.
So let us see how many of these patients which we think are resectable and we resect them will require adjuvant chemo.
So they will require,
Exactly.
but
So on one hand we keep on saying it's people tolerate
no, but we have
neoadjuvant
better
chemotherapy.
evidence. We have better evidence in resectable disease with complete adjuvant chemo. So if you
Right.
do good quality surgery, they will do well. with
So
adjuvant.
this is the study which negates the efficacy of neoadjuvant chemo in a patient who is resectable. If you look at radiologically resectable pancreatic head cancer, so 63 patients underwent upfront surgery and 77 had neoadjuvant FOLFIRINOX, and then of course it was surgery in between, followed by the subsequent balance 8 cycles, and there the adjuvant FOLFIRINOX. And if you look at the bottom line here, the median overall survival actually is poor in patients who got neoadjuvant chemo. So I think the message is clear that if you have a resectable pancreatic cancer, I think you should go in for upfront radical surgery and follow it up with the adjuvant. Any comment? Yeah.
So
I don't think there's a debate about what you're saying. It's only, I mean, if you have to give chemotherapy, I would prefer the patient gets chemotherapy before. That's the philosophy I want to make the most of it in the beginning. When the patient is fine. You never know, however good surgery you do, the chances of,
So that data is clear for borderline resectable. So I think, but not for upfront. Yeah. So the question, yeah.
So does the location of the tumor makes any difference? Tail, neck, or head?
Situation where if you are talking what she partly referred to, an uncinate process tumor, the chance of your R1 resection is going to be higher with an uncinate pancreatic ductal adenocarcinoma.
Even it's operable
without
on the scan.
without vein resection, you can easily mobilize and remove it. But an uncinate process tumor, the risk of an R1 is higher than a tumor which is away from the uncinate. This is known. So this is in the morphology itself. Both are resectable, but the location might influence.
So uncinate you will send us for the neoadjuvant?
You say uncinate which is high on CA19-9 with some lymph nodes, 100% resectable. But the thought that I should start looking at neoadjuvant will definitely come in the resectable category. But it is coming, there is no real evidence
Yeah, I know
to
there's
justify this.
but since you all have been working at high volume centers, so that's what I wanted to understand. So in the tail you wouldn't send, in the
A resectable disease, no.
Yeah. But for the uncinate we would like to give chemo.
Sometimes. Very selective.
yeah, so the NORPACT-1 did not show a benefit, and I'm not a propagator of chemotherapy in resectable pancreatic cancer, but just to point out that there are a lot of problems with the study. It did not take into account the CA99 levels. It takes into account T1 and T2 tumors also.
So more data need to be generated. So So let me, since the medical oncologist is here, so we have very strong data for pembrolizumab in rectum, in upper GI, stomach, and colon. So in a resectable patient, will you do MSI testing, HER2 testing, and whatnot you have, and you find it's a MSI high? So would you give pembrolizumab upfront before surgery?
So I would be tempted to, but there's no data, sir.
Right. So I think he nailed it, and but we certainly should be looking at that kind of. The incidence of MSI high is just 1%. Actually, that's the whole problem. So that's a problem. So but MSI is such easy test to perform, and the data which is available for GI cancers is very robust, and it has come in NCCN guidelines for using pembrolizumab or nivo-ipi before doing surgery. In fact, you can even perhaps avoid surgery. So, Shailesh is smiling.
But probably that's the way forward, sir. DDR deficiency is around 25% in pancreatic cancer.
Yeah, but that's different. So the MSI high has a different meaning because pembro is so effective there. So I think the borderline resectable cancer CT and or CT-RT was extensively covered in the previous discussion and lecture. So should it be chemotherapy? Should it be radiation added? Chemo of course is on, there's no discussion. So I don't know when to subject them to radiation because the data is still not clear. Deep.
So in our practice, we would say if there's a very large tumor, you give need-driven treatment, reassess after 4 cycles as discussed. If no response or very marginal response, maybe add radiation at that point of time.
Right.
Or from the beginning, if the tumor size is very big, add radiation along with chemotherapy.
Yeah, correct. But as I was telling that the randomized studies have not sort of supported the use of radiation in the neoadjuvant setting. And in fact, at ESMO yesterday, the PRODIGE 44 study has been released, and it says that you have same rates of R0 resection, same overall survival, only thing is you get a little more PCRs. So it doesn't translate in terms of higher R0 resections, and same is the data here, which is shown in CONCO 007, that the radiation is, but I think you can select out cases depending upon your result. So I think we can come to the last part of the discussion, which is the metastatic pancreas cancer. So Dr. Sushant, if you have a patient who's very well preserved, so what is your protocol there?
So for well-preserved, FOLFIRINOX can be offered, but otherwise in Indian scenario, more than 50 years of age, it's difficult to tolerate. So gemcitabine or nab-paclitaxel or capecitabine, that's what we follow.
Right. So there's this other third protocol which has just emerged, which is expensive, which is the Napoli 3, where they use the liposomal irinotecan, which has just become available, and you can see that the survival in these patients is 17 months, 14 months, and so on. So I think it is very simple to understand that if you're using FOLFIRINOX first, you have the non-cross resistant gem nab-paclitaxel in the second line. And at what point in time do you do the NGS or other biomarkers?
Nowadays, since we have very limited options, so I counsel the patient upfront, and by the end of 3 months or 4 months, they get convinced to do NGS. What's the importance of NGS?
Right. So what are we looking at when we are doing NGS? Because this is the slide which shows that.
So yes, these are the genes, but the possibility of having a useful drug out of these is very less.
Right. So I think the only important situation is to look for BRCA1 and BRCA2, because it has two connotations. One is to use a platinum upfront in these patients along with, say, gemcitabine, because they are platinum sensitive. And then, of course, to put them on a PARP inhibitor such as olaparib or rucaparib in the maintenance. And as I said, MSI high, if you get any anecdotal experience with these targeted drugs in patients with pancreatic cancer?
No, I have not used it, sir.
So we had one patient who had failed chemotherapy, and we did the MSI, and it was high, and we gave him pembro, and he could not afford beyond 5 or 6 cycles. We completed in about 4 or 5 months, and he's going on 2 years now without treatment. He couldn't afford, because he said, I have no money, sir. So I mean I can't steal from anywhere. But the point I'm trying to make is these immunotherapy drugs, if they work, even if you stop because of shortage of funds or some side effects, they can be lasting effects. So must do the MSI, and now you have the HER2/neu, which again, is not very common in this situation. We have the drug which can be used. So I think the tumor somatic gene profiling is recommended for patients with locally advanced metastatic pancreatic cancer who are candidates for anti-cancer therapy. And I think NGS is so readily available. Sometimes the issue is the tissue, because you get an FNAC and you don't have the block to perform this. Now the liquid biopsy is also available, but then I think we need to have that habit of putting these patients for next generation sequencing. So I think this is what I thought I would say here, because most of the things were said. Any comments from the panelists, Dr. Shikha? Any role for radiation in metastatic setting?
Yes,
Yeah.
that's what I want to say. Dr. Sailesh has said a lot of practice has changed over last 10 years. I would say a lot of practice will change over next 5 to 10 years, because you see with SBRT and high dose per fraction, we are changing the microenvironment of the tumor with antigenic antibody. So all these immunotherapy drugs and the PARP inhibitor, they will act much better.
Right.
So I hope,
Yeah, I wish you are true, but I think we are.
So that will know in next 5 to 10 years, isn't it?
Right. So I think the KRAS gene, which is mutated in most of the pancreatic tumors, so the drug which is available is for K12C. There are a couple of drugs, sotatercept and adgressib, but I think the other KRAS mutants are not available for drugs. I have a slide here, I think, if I can show you. Unless you have a KRAS inhibitor, things are not really going to change in a big way. So these are some of the targetable mutations, as you can see, MSI high or high TMB, NTRK fusion, KRAS G12C, which is said aggressive and sotatercept, BRAF mutation, we have the drug, NRG we can get the drug, RET we can get the drug, ALK we can get the drug. But I think the KRAS mutants are the most notorious at this point in time, and pan-KRAS inhibitors are being developed with strong conviction in the positive outcomes. So I think with this, yeah, doctor. Right, so that's interesting question. If Sushant wants to take low dose immunotherapy in cancers in general, let me put it, rather than pancreas cancer, yeah.
So sir, for head and neck, we have the data from TMH and we have been using that. But other than that, none from anything outside India. I think only in India that trial would be conducted. But as of now, I am not aware of anything.
No, so I think let me just rectify this. So I think a lot of data from India in head and neck cancer has emerged. Tata was the one which took the lead, but I was just reviewing some of the abstracts which were submitted to us for our ISMPO. There are at least 3-4 studies coming out from India on low dose, nivolumab or pembrolizumab. But more recently, from US in lung cancer, they are documenting the efficacy of low dose pembrolizumab in lung cancer. So that data is preliminary, but I think people are looking towards that. So I think in the next few years, 1 or 2 years, so we'll be able to save money and give the perhaps similar efficacy. And then of course the generics are on the way in the next 1 year or so, which again will help us, providing these drugs to a lot of our patients. So I think the data is on the way. So this is the KRAS slide on the pan-KRAS inhibitors. You can see, almost 60-70% patients in the waterfall plot responding. But these drugs are in the pipeline, and maybe in a couple of years you will have in hand. So it is currently approved in first line. Instead of irinotecan, you use liposomal irinotecan. If you have used GEM Nampacli, then you can use in the second line also in the Napoli 1 study. So you have Napoli 3 for first line and Napoli 1 for the subsequent line. So with this, thank you very much. Thanks to the panelists for the interaction. Thank you.
Thank you, sir. And thanks, panelist. Okay, wait. So, before we call upon the next, our guest speaker, I just want you to go through this slide. Alan Whipple, yes, Alan Oldfather Whipple. He is the famous American surgeon who is known for developing the Whipple's procedure, and he is also the very senior surgeon, and he, in his life, has modified many lives during his course of developing the technique of performing Whipples. And similarly, I think Dr. Adarsh Chaudhary has touched many lives in modifying our career as becoming what we call as, a part of the journey which we deal, the pancreatic surgery. I think he has taught us it is more important to know that what not to do and when not to operate, and when you are in trouble, what to do. I think we are lucky that we are being touched with his words of wisdom, and I invite Dr. Adarsh Chaudhary to kindly come here and please present your lecture for us. Thank you.
Thank you, Neeraj, for inviting me. I'm supposed to speak on what happens, what to do when a pancreatic leak occurs, and I think what you mean is when you have a grade C pancreatic fistula, what do you do? First thing to do is to panic and to realize that it shouldn't have happened. Fortunately, when I was young, it used to happen more often, but now the reported incidence is about 2 to 12%. And the level 1 evidence for managing such patients does not exist, because fortunately there aren't too many patients which go through this. A lot of this treatment is very subjective. Am I right, Shailesh? That it's very based on individual approaches. So I'll just go through a patient which we managed a few months back, who underwent classical pancreatic duodenectomy, uneventful. He was obese, he was diabetic, but remained all right. And on third post-operative day, we realized his urine output is dropping and he had higher Riles tube aspirate. So for us, a critical care pathway is a very important determinant, not to discharge patients early, but if patients do not fall into a trajectory of normal recovery, things are amiss. If a patient on third or second post-operative day has fall in urine output, the blood sugar is rising, it's a surrogate marker for something happening. So you see, drains are very, we believe they work, but drains are very sensible. When they have to work, they don't work, they get blocked. So in a patient who has no leak, the drains work well, but once leak occurs, the drains invariably get blocked. Like in this patient, the drain amylase was high, serum amylase was normal. So we knew something is wrong in this patient. So on post-operative day, patient didn't get well, urine output was maintained, and there was tachycardia, leukocytosis. The drain was still about 30 cc serous. It was not working, we removed it. And we believe that an early CT scan should be done, and we did a CT scan on this patient. It didn't show much, it only showed distended stomach, some peripancreatic fluid. Normally we stop antibiotics on second post-op day in this patient. We didn't stop antibiotics. We started this patient on parenteral nutrition because we imagined that this patient we won't be able to eat. On post-operative day, there was some altered blood in the nasogastric tube. There was no hypotension, marginal tachycardia. So what do you think should have been done, an upper GI endoscopy or a CT angiography? So how many of you in the audience want to do an upper GI endoscopy? Can you please raise your hands? And how many of you want to do a CT angio? I'm glad. Okay. So we did a CT angio in this patient, and we found a gastroduodenal artery aneurysm, as expected, though not as desired. The stomach was distended, he had dilated bowel loops. There was peripancreatic fluid, and at that time the priority was to embolize this gastroduodenal artery aneurysm, which was embolized at that time, and we consulted our intervention radiologist also that if that fluid can be drained, but he said the fluid isn't much and it shouldn't be drained, we can just observe this patient. So we manage these patients with antibiotics, parenteral nutrition. We stopped heparin because we routinely give heparin to our patients, like low molecular weight heparin to our patients. We stopped it. We started this patient on octreotide. You might ask me if there is strong data. There is no data, but when you are pushed to the wall, you want to do everything. So we started this patient octreotide because we knew that there's a pancreatic leak, And the most important thing is we counsel the attendants that there's a cloud on the horizon, things are not going well as we expected. So on post-operative day 9, he had fever, he had abdominal distension, his gastroparesis was persisting. We again repeated a CT scan, which showed a significant amount of peripancreatic collection. And then we asked our interventional radiologists. So we put drains on these patients. We used to irrigate these drains. We continued antibiotics. We gave him octreotide. We gave him nutrition. And this patient stayed in the hospital 34 days. He had 4 attempts at drainage. Overall, he had 6 CT scans. And when he was discharged, he still had a controlled sort of a fistula, but eventually took 3 months to get well. He later formed an incisional hernia, which later was repaired. What is the guiding philosophy in managing a patient who's got a grade C pancreatic fistula, apart from antibiotics, routine management, octreotide? Most important thing is repeated imaging and drainage. Commonly what happens is patients, we also used to make a mistake in the past, that what we will do is we presume that one CT scan is normal. We won't repeat a CT scan for next 4 or 5 days because we will think that the previous CT scan was normal. So we believe essentially you should keep doing imaging, get intervention radiology to put drains, and we believe irrigation of these drains is very helpful in managing these patients. The difficult question is, when do these patients need surgery? It's a very difficult decision. There are no rules of thumb. You have to see how the patient is recovering. If you think your percutaneous drains, which are put by the radiologists, are working, patient is not septic, is improving, then possibly this patient doesn't need surgery. But there's another patient who has, in a short span of time, getting multiple drains placed, possibly it might be better to operate these patients. Because a single guiding philosophy in these patients is to drain any intra-abdominal collection, convert it into an external pancreatic fistula, look after the nutrition. So it's very difficult to decide when to operate, but if you need to operate, you better go in early because the window of opportunity closes very rapidly. Of course, if a patient has got bleeding, you have bleeding from drains, profuse bleeding, you have no choice but to operate these patients. God forbid if you have to operate these patients, what do? It's a great lesson in surgical science if you operate these patients. When you operate, majority of times when I operated, I have seen, we believe sutures and things work. I've seen the pancreas lying here and the jejunum lying here and the stent lying in between. Things have fallen apart, and actually many times you can't even make out what is happening where. It is so difficult to see this, everything is friable, everything is oozing. And what can you do? If you operate early, I think the safest option is to do extensive lavage, clean all the necrotic material, put big drains, take out the stent if you placed, put a stapler on the jejunal loop. If possible, you can find the pancreatic duct, put an infant feeding tube into the pancreatic duct, and you put it in a way, make sure it does not slip out. Because it's a small tube, it has a great propensity to slip out. So the best option is to do an extensive lavage, put thick bore drains, put a tube into the pancreatic duct, and hope and pray that it works. Should you do a completion pancreatectomy? I have done a completion pancreatectomy thrice in my life because in all these 3 patients, there was extensive amount of pancreatitis, there was localized bleeding. So it is not actually a pancreatectomy, it's more like a necrosectomy. You take out the diseased pancreas, and of the 3 patients I have done, 2 patients died and 3rd patient had a very bad course. If you have to do a completion pancreatectomy, it means your intervention was very late. Mortality in patients who have grade C pancreatic fistula ranges from 20 to 70%. In patients who undergo surgery, If you operate a patient once the organ system failure is established, mortality is close to 90%. And in a patient in whom you've done a surgery once, if you have to reoperate this patient, mortality again is nearly 90%. So resurgery after one surgery is a very ominous sign, and these patients are very sick and they do not tolerate it. There's one paper which was interesting, which again emphasizes the importance of drainage. And this is targeted as a draining tract targeted. What it means is, if things are not going well very early, you do a fistulogram, find out where your drain is placed. If your drain is not properly placed, you place a guide wire, put a proper drain, replace the drains with the drain which works, and drain irrigation. So in this paper, patients who underwent a draining tract targeted management, outcome was much better. There are no long-term or large studies. There can't be any studies in this. Essentially, everybody emphasizes the value of early intervention and early drainage. But my experience is that whenever I've realized that I have mastered the technique of pancreaticoduodenectomy, a leak occurs. So humility is most important when it comes to pancreatic anastomosis. All of us are amateurs. In my experience, my best anastomoses have leaked and my worst anastomoses have worked. So this is my last slide, and I'm very happy to discuss with you any questions or comments that you want to say. Thank you very much. My biggest question I cannot answer myself is, what is the time to operate these patients? C-reactive protein, all these things are surrogate markers of what is happening. I really do not know exactly when to operate, but now I believe the threshold of surgery, if you want to do, is earlier better than later.
So my question is, suppose a patient is not doing well in the 5th day, even if there is no bleed, normally what I do is I get a CT angio.
Yeah. I agree with you. Absolutely. I absolutely agree with you. I absolutely agree with you. I mean, like I'm saying, that the dictum is image, image, image. One normal image doesn't mean everything is good. I agree with you. I absolutely agree with you. I absolutely agree with you.
So I think I agree the same, and I think the standard dictum in our team is that if we ask for a CT scan, there is nothing like a plain CT scan. It has to be a contrast enhanced CT scan. It has to be a CT angio with all the critical vessels evaluated. The other good point you highlighted is that this is a dynamic process. So just because a scan was good 4 or 5 days ago, if you are clinically seeing the patient more often and realizing that things are not looking good or not even improving, even if they are not improving, it's relative deterioration.
That's right.
And then we should not match it with the CT but repeat a CT scan. And I think the other thing is the big question, when to operate and when not to operate. But I think that question is getting more and more clear over time. Operating in a situation where things have worsened a lot
is no point.
Cannot have an outcome which is going to be much better when the patient can withstand an operation. So I think the minute I feel there is going to be a need for more than 2 pigtails, the thought of do I need to take the patient to IR or one good exploration now is worthwhile, is a thought which starts to cross my mind. So I've kind of made it into a clear thing that anything more than 2 pigtails, think twice whether we should open.
And Shailesh should also agree that I believe more in patient's well-being than radiology.
Absolutely.
If a patient is not improving and radiology shows things are better, I better operate.
Absolutely.
I better operate.
And
radiology is so subjective,
And 5 cc collections in some patients
is more dangerous than 200.
Can be relatively very dangerous.
Excellent. I agree with you.
We can't look at the collection size and decide what to do. We have to look at the patient.
I always say I treat patients, not reports, because it's so difficult to assess. So
exactly.
difficult. I'm glad you agree.
Also, I think, sir, the biases needs to be obliterated, because the surgeon who is operating obviously have certain biases. I think it's a good idea for somebody else to look at the things and
The patients who regularly do pancreatic resections have no biases. We are always scared. Over-realize I have failed so often, I have no biases. For me, like I quote, Shailesh quotes me very often, even if you have paronychia, it's a pancreatic leak. I think if a patient is not doing anything, it's a pancreatic leak. I'm obsessed with it.
But I think
They should not be doing it. They should not be doing it. We should be doing all of it.
So, so I think, but
the,
I think
the only purpose of these talks is that ordinary people should not be doing pancreatic surgery. We are the only ones should be doing it.
yeah, that's clear. That's the whole purpose. But I think the important point that Deep is trying to get again for younger people, not just in pancreatic surgery, but any surgery, if things are not going well after you are the primary surgeon, it is always worthwhile to take the help of an additional fresh hands and fresh eyes and fresh mind. You will be much better off. There is everything in teamwork, and teams win championships. Talent will win matches.
And Shailesh, also have people in the team who disagree with you.
Absolutely
We
fine.
have people disagree with you. That's why we like Diksha.
Very good.
So always people who disagree with you work well. So, I mean, if everybody says yes, why have a meeting?
Yeah.
Why have a meeting if everybody agrees with you?
I think
So thank you so much for
true.
this thing.
Very good.
Can I go?
Thank you, sir. And that's why I told you in the beginning what not to do. I think everybody should refer the cases to him only, sir. so okay. So thank you, and it's been indeed a very good morning session for us. And now we head towards inauguration. We have an honor of having our chairman, Dr. Ajay Saroop, Dr. Bhalla with us. I request Dr. B.B. Agarwal to kindly come and give the insight, and then we request Dr. Saroop to come and say a few words.
Thank you, Neeraj. Good morning, everybody. We are grateful to you all to spare time for this meeting and enjoying interactive academics. I feel very privileged to be part of a team which has done foundational work for safe laparoscopic cholecystectomy, hernia repairs, and now we ventured into pancreatic surgery in 2015 with minimally invasive techniques. And it has brought us to the point when we have generated debates and more people are getting interested in pancreas. And all credit goes to the youngsters in the team, Neeraj and Vasu. And it would not have been possible if we did not have somebody to guide us, bless us, and support us. And Dr. Vijay Roda, who is the advisor in our department, has blessed us to pursue all these things with the blessings from the soul of Dr. K.C. Mahajan. Pancreatic surgery is a teamwork, needs a lot of support apart from surgical skills in terms of infrastructure, support when you're emotionally down, when you're facing problems, Dr. Adarsh Chaudhary narrated. So Gangaram is a place where we are blessed by our leadership, led by our trust chairman, Dr. D.S. Rana, and Dr. Ajay Saroop, who has been my teacher since my MBBS days, who has always supported and encouraged us to pursue whatever we want to do as far as it is in interest of the patient and in interest of academics and continuing research. The blessings of leadership have percolated to us through every member, Dr. Bhalla, Dr. Bayotra, Dr. Jayashri Sood, Dr. Satnam Singh, and Dr. Rawat, who is a dear friend. I met him, but I don't see him now. So we are all grateful for everything to our management, leadership, and senior teachers like Dr. Vijay Roda. So thank you very much for coming on this rainy day in a busy traffic. Thank you. And I request my teacher and guide and mentor, Dr. Ajay Saroop, to please say a few words of guidance to us. Please, sir.
Good afternoon, ladies and gentlemen. Yeah, there are few ladies here. Good afternoon, ladies and gentlemen. On behalf of Gangaram Hospital, I welcome you all to this advanced discussion or seminar or whatever it's called on pancreatic diseases. Since the very beginning, pancreas has been a mystery organ, and it has always been difficult to diagnose diseases arising from the pancreas, and even more difficult to treat it. So now, with so many stalwarts sitting here and exchanging notes, I'm sure some SOPs will emerge by which ultimately the patient will benefit, because the the ultimate aim of all of us sitting here is to somehow improve our results as far as patients are concerned. So I'm sure this will go a long way in bringing new ideas in the management of pancreatic disease. And I wish all the success to this seminar. As most of you are aware, Gangaram Hospital has always been at the forefront of academics. The management and our founders, stalwarts, which he has mentioned, Dr. Mahajan, Dr. Bora, Dr. K.P. Jain, from the very beginning they have inculcated this ethos of academics. And it is especially true nowadays with such rapidly advancing science. Today what we know may be obsolete the next week. So it is always better that we contact each other, we remain in contact with each other, we learn from each other, and that is the purpose of these sort of conclaves, which we have many in every department. So once again, I welcome all of you and wish this conclave all the success. Thank you very much.
So as we're going green, we're also going green with the lamp lighting ceremony. And I request all the dignitaries and the daily SI dignitaries, I'll start with naming Dr. Swaroop, Dr. Bhalla, Dr. Vijay Arora, Dr. B.B. Agarwal, Dr. Chintamani, Dr. Deep Goyal, Dr. Pradeep Jain, our guest, Dr. Shailesh, Dr. Adarsh Chaudhary, Dr. Singhal from ASI, Dr. Hukku, please come. This will also be a group photograph for all the esteemed faculty. Dr. Dogra, Dr. Day, our secretary, Dr. Tarun Mittal, if he is here, the GC member, Dr. Sameer Nain, Dr. Arvind Kumar, Dr. Arvind, please. Yes, Dr. Tarun, please come. And all the members. Dr. Sumit, you can also come, please. Dr. Arvind, please. Dr. V.K. Malik is there or not? Dr. V.K. Malik. If I'm missing anyone, please guide. Everyone, now we'll have a break for lunch, and after lunch we'll having an interesting video session on pancreatic surgery and the wet lab wet lab will be just to the enjoining hall B. Okay. So post lunch we'll meet here. Thank you. Please. just refine the steps of the Whipples, which were initially described by Eleanor Father Whipples, and also guide people to perform surgery in a way which was better for the patient. And he was also known that one particular interesting aspect of Warshaw's work was his patient-centered approach to pancreatic surgery. Warshaw's wasn't just known for his technical skills, but also for his compassion and care for his patients. And in a widely shared story, once a patient asked him, "How long do I have?" To which Warshaw responded, "We'll take it one day at a time and do everything we can to give you the best days." And such patient-centered approach I have also seen with Dr. Chintamani, who is the moderator for the next session. I request Dr. Chintamani to please come and one by one introduce our next speaker. I would also have a slide for each one of them. We have already described how meticulous and dedicated Dr. Shailesh is, who is our first speaker for the video session. I request Dr. Chintamani to be on the dais, and I request Dr. Shailesh to kindly come and start his presentation.
You know, even after
He won't need introduction, so that's an easier job to do. And whatever you're going to listen in next 20 minutes or so and watch is outstanding. I've seen him for a very, very long time. Association goes back 20 years. So over to you. No. I mean, we're looking at somebody who will create those landmarks that you would all need to follow. Over to you, Shailesh.
Thank you so much. Can we have the screen share? Before I talk about the video, which I'm going to show, and I'll keep everything within 20 minutes, a brief background as to what you are actually going to see in the video and what helps us. And that's very brief. Be aware of the SMA first approach. There are 6 approaches that you need to be aware of. You might have to use different approaches in the same case based on the tumor location. First message. Second message, be aware that when you do a Whipple resection, there is LV1, LV2 and LV3. LV1 is conventional Whipple, LV2 is vein involvement, LV3 would be vein plus right side of artery involvement, and beyond LV3 is subadventitial dissection, where you go underneath the adventitia of the artery. A risky procedure. You need to be prepared for an arterial resection anastomosis, but sometimes you can avoid an arterial resection anastomosis and yet get the tumor out. So LV3 and beyond is what you should be used to, apart from SMA first. Simple vein resections, SMA first, isolate the artery, tumor hangs on the vein, simple resection anastomosis, 5-0, round body, Prolene suture, double-ended needle, running suture. In 12 to 13 minutes, the anastomosis is done, provided the entire specimen is hanging on the vein. For that, you must be comfortable with the uncinate first approach also. So even in simple cases, please try to do a complete uncinate dissection without dividing the neck of the pancreas. The easier part is to divide the neck, then manage the uncinate the way we would do conventionally for a Whipple. And as you know, only 2% of Whipples are done minimal invasive worldwide. So everyone does predominantly open Whipple even now. On this background, you should also be used to doing the uncinate first, so that the tumor is hanging only on the vein. Then you can do a vascular resection very easily. Some cases, thanks to good radiology, you will be able to identify other tributaries which are draining into the liver, and you can resect the SMV, not the portal vein, but you can resect the SMV and close the SMV, and yet the collaterals will take all the blood back to the liver. So some of the tumors which go into the mesentery, into the infracolic compartment, all of them are not necessarily unresectable, especially if they get better chemotherapy, radiotherapy, or in cases of less aggressive tumors such as solid papillary epithelial neoplasms, neuroendocrine tumors. You may do a vein resection without reconstruction. So that's my radiologist helping me. For a lawyer who had a tumor of the SMV, and the problem was the reconstruction below. And she was a lady in her late 40s, completely fit, walking into the clinic, already rendered inoperable somewhere else. This is what I've done. The 2 bulldogs are clamping, and I just went away for a coffee, made sure that the bowel was absolutely pink and nice. There was no problem. And then there was no resection done, but no reconstruction done. So you can do a VROR also. So be very good with your radiology when you plan your vascular resections. The next thing after doing vein resections is also to look at the smaller artery resections, and this is a hepatic artery which is resected. The splenic artery is divided and joined back to the right and left hepatic artery. If you are a transplant surgeon, you might do artery anastomosis on your own. If you are not, however skillful you may be, it's best to get a vascular surgeon who does this day in and day out. They do a better job than you do, however great a surgeon you may be. So we have done in the past, over 8 years, 63 of these upper end procedures. And this is an example of a simpler case, just a vein involvement, dilated bile duct, pancreatic duct, chemotherapy given. We discussed this in the panel before. You can see the white area of the portal vein. Control is there, pancreas is divided, tumor is hanging on the vein. That's the danger area where you are going to get all positive resections. And that's the triangle tissue between the SMA and the celiac axis. This is a part of your complete clearance. So don't forget the oncology when you plan a vascular resection. And that's what I've shown you in this picture. And then you can do a primary end-to-end anastomosis, a type 3 ISGPS pancreas anastomosis. We've got good results with 201 cases in the past. This was published in 2021. This I told you was published earlier, 2007 to 15. More recently, this number from 63 has now gone to 197. So we are also a center which is constantly evolving with more extended resections for pancreas cancer if they respond very well. The upper end is that you have a celiac axis, and this is what we discussed in the morning without reconstruction, that we have done a modified Appleby procedure, celiac axis is resected. Now you can't do this operation well if you are not used to SMA first. You can't do this operation well if you are not comfortable with the pancreatic neck and body. You can't do this operation well if you don't know how to do a D2 radical gastrectomy by working on the right and left crus of the diaphragm. So unless and until in simple cases you go in all these regions, you will not be able to do that difficult case. But if you sweat in peacetime, you will not bleed in wartime. So remember this when you plan vascular cases, and then you can get resections like this. Incidentally, this lady is doing well for over 3.5, 4 years, but she has developed a recurrence now, but she's lived for more than 3 years. We have large number of volumes. We have evolved over a period of time, but this all requires learning curves, and learning curve is a loosely applied term. But there is something known as a learning curve, and there is something known as a proficiency curve, and there is something known as a mastery curve. So it's a long journey for us as surgeons for the whole of our lives to keep on learning. I still keep on learning every single day, including a right hepatic artery reconstruction, which I have done yesterday for a case of Whipple resection. So as I said, more surgeries coming our way, more complex surgeries coming our way, all the more that we need to specialize in this, especially vascular resections. Now the videos will start. So many fellows are here, so many people are here, and I thank all of them for all the work that they have done with us. But now the video, which is a 9-minute first video, should I show you the vein resection first and then the artery? And it will finish in that time. It's only a video now. You will be relieved that I am not talking. Are you controlling? नहीं, दूसरा वाला लगाना. हाँ, वो वाला लगाना. Thank you. So this was a live operative demonstration at the Tata Memorial Hospital for OncoSurge, I think in 2022, soon after, towards the end of COVID, when we again had a live operative demonstration. And usual Cocker maneuver in the beginning. That's the inferior vena cava, left renal vein. Cocker means expose this and then also expose the takeoff of the SMA, the superior mesenteric artery. Then we go anteriorly. I'm separating the transverse mesocolon to get the colon away. It can be puckered, it can be tethered, especially if there is a vein involvement. We are now in the lesser sac, getting to the loop of Henle. Vein is slightly dilated expectedly because my tumor is exactly at the level of the SMV. But I had problems in this case is my memory. This was a live demonstration and I'll show you the problems that I faced. So this is the SMV and this is LV2 and I'm exposing the SMA to the left of the SMV. The camera is over my right shoulder. So now what we are doing is separating out. This is the anterior tethering, which is not much. This you can easily manage to take it out. But don't get confused. There is a tumor which is behind posteriorly, which we will show you afterwards. For constraints of time, I have not shared the pre-operative video with you. The longer video has that CT scan also with a video. Then the easier part, station 8A, dissection of the porta hepatis, exposing the portal vein and the common hepatic artery, getting the pericholedocal nodes away, the relatively non-dilated bile duct being divided and taken away. I deliberately kept the gallbladder aside for the view and for people to see. This can be revised afterwards when you get the gallbladder out, and if required the margin positivity comes in, but usually not unless you are dealing with a cholangiocarcinoma. Distal end is closed, and then we get that out, and now we expose the GDA, the gastroduodenal artery. We will do a clamp test to make sure that there is no celiac steel or there are some other problems. So every step is the same standardized approach. Put a bulldog clamp, check the common hepatic distal to the clamp, also check the right and left hepatic. Make sure you are totally safe. Keep a good stump with the patient, and then bear the portal vein. Now I am inferiorly. I knew that there was no involvement anteriorly as far as the neck of the pancreas is concerned, and the problem was going to be posteriorly. So now I am preparing the pancreas for transection. Then I go infracolic compartment, and you mobilize the adequate limb of jejunum, because as per embryologic development, you require the complete uncinate process to be splayed out in your hand. In this case, I have divided the neck of the pancreas because the bulk of the lesion was in the uncinate and behind the neck posteriorly. Flimsy adhesions are separated, but now I come to the point where the posterior involvement is there. Now you see, this is the posterior involvement. So superior mesenteric vein resection is going to be required, not portal vein. So I'll control the areas which I can control well. The splenic vein is above the neck. Now this is the easier part, but behind is the more difficult part, and the uncinate was exactly there. For the size of the patient, I could not do a complete uncinate first. This is what I'm showing, that I could not do a complete uncinate first, and I decided to deviate from normal. That I said I will resect the vein first, but look what happens now. I'm showing you a complication. The blood did not stop after the clamps. The answer is that the jejunal vein was still draining, and this was not easy. Now I applied a clamp on the splenic vein also in the hope that it will stop. It still didn't stop. You require an experienced assistant who is just putting a finger over there and keeping the suction. I continued the surgery where I divided the vein. I said I need access behind. That was the oozer which you saw now. I got it away, and now the vein is divided inferiorly. But I immediately can't do the reconstruction because this was the tumor behind. So this did cause me some coronary problems, but hopefully the collaterals have also developed in me well. But this was fine. It was good fun. You have to enjoy these surgeries also, as long as it's in patient interest. So then this was done. And now I could go to the remaining uncinate, which in simpler cases you should do first. So I'm showing you a variation of a vascular resection, where ultimately it took me a good 20 minutes after the vein has been divided. And then I started the reconstruction. That's the easier part, that you have 5-0 round body needle. I do not put any stay sutures. I just apply the clamps, say from lateral to medial, so 9 o'clock to 3 o'clock, so to say. Take the posterior layer under vision. Make sure that it's a precise approximation. Respect Professor Halstead, who's taught us everything as regards tissue approximation. And then the other end of the proline, again from the assistant side to your side if you are a right-handed surgeon. So the anterior wall is always easier and faster. The actual anastomosis will take 9 minutes to 12 minutes. So best is to have a specimen hanging and not the case which I showed you. But anyway, make sure there is no thrombus, make sure there is no tension, and then you close this anastomosis. So now this resection is done post chemo. This is SMA first, everything is clear, and we could clearly show there was no problem. But we also wanted to see the bowel after 40 minutes, and the bowel is also not bad. So you control things and then you are able to do. I'll stop this case here because I don't think I need to show you the pancreas anastomosis. We have the other videos. Am I right, Dr. Neeraj? So I'll stop here and I'll show you the next video, which will hopefully finish everything in time. Can you close this? And the next video. This is amateur, but this is real. And this is a case where I have done arterial divestment and reconstruction. 66-year-old patient, upper abdominal pain, weight loss, no secretor, non-secretor. And this is another tumor, not the same as morning, but similar. Pancreatic body, hypodense mass, encasing celiac, more on the left. Right hepatic arteries coming early. This picture is important. Can you go back? Can you go back a little bit? And pause here, 1 minute please. Pause, either pause kariye. The middle picture shows a funny artery. And that's here. There is one artery here and there is one artery here. Both are hepatic arteries. That's the splenic. And I'll tell you why this is important when you see the video. So understand that there are two hepatic arteries, anterior and posterior, right from the celiac. And then you see the last picture where there is portal vein involvement, which is only to the left side. Okay, next. Continue. Ten cycles in this case, chemotherapy plus radiotherapy. We have a philosophy that closer to the arteries, sometimes we will add radio. This patient also got radio. Disease was stable, patient was fine, but no big reduction in the size of the mass, even on response scan. Plan was to do a posterior ramps and as far as possible divest the celiac axis, common hepatic artery, and that right hepatic artery which I spoke about. Now camera is from the surgeon's right shoulder. Assistant is retracting. And now we are going, we have exposed the SMV and we are going to the left. So now again it is exposing the SMA to the left of the SMV. The splenic vein is divided in this case. Earlier on we could kind of move it away, so vein resection was not required. Those two white clips are there on the splenic vein. But a fat patient, and we have to go down the SMA. Remember, the SMA goes down, so we are now tracing the SMA, and that's where the SMA is, under my energy device. If you are uncomfortable with the energy device, use a scissor, use a mixed, use a bipolar, use clips, use Prolene sutures, because you have no control. You are going down to the SMA. Of course, you've done a Cocker maneuver and exposed the SMA posteriorly as well on the right side. So the whole aim is to go to the celiac. Now look at this. This is the main portal vein, SMV. The celiac is involved by the tumor. The neck has gone for frozen section. And now the triangle tissue between the SMA and the celiac and the hepatic is being taken. Now we are going to be doing the divestment of the common hepatic artery, which I will show you. One is LV3 and the second part will be subadventitial divestment. So now this is LV3, periadventitial. Just cleaning everything, sending this for frozen section. If this is negative, you know that you can try and avoid an artery resection, but you can get all this tissue out. So you require dedicated frozen section. You keep tracing the artery and you have control. But you will see the difference in the caliber. See the caliber distally, it's so thick, and then see the caliber proximally, it is thin, because we have done divestment, which is subadventitial here. That's the divestment. And the other one is neurofibromuscular vascular bundle is intact. Now remember that the right hepatic artery is also to be safeguarded. The tumor is being retracted by the assistant, who can't retract more because that will yank off tissues, but can't retract less because then I can't see. So I want to safeguard that right hepatic artery. I don't want to accidentally hit the origin of the celiac axis. I have no access in this case to the celiac axis in the beginning. So bit by bit, this case is about 7-8 hours of surgery, and just an amateur video recording was ongoing side by side. But You see now the common hepatic is coming, the right hepatic is coming. Now you see much better. Common hepatic, right hepatic, splenic origin encased by tumor, celiac origin is seen. So now we go to the celiac all around before we come to the point where there is a left gastric artery also being delineated. This case also has a surgical problem on table, which I will show you why a vascular surgeon is required. I know I'm taking a few minutes longer, but I'll be done. Is that okay, Dr. Neeraj? So the heart tumor post chemo radio and trying to free up as much celiac axis as possible. Now you see the CT had not shown that we had such a length of celiac possible. But after dissection, you are able to see that we have the root of the celiac available. So we were prepared for a direct clamp on the aorta, but here I can clearly show you that chemotherapy plus minus radiotherapy does work in selected patients. And this was margin negative resection finally, just to let you know. The patient is still doing well. This patient incidentally is a doctor who is practicing for the last 2.5 years since this surgery. So now see how thinned out the artery is looking, because we have divested it completely. Of course, all bulldogs are ready. And when I go to the splenic artery, I will be applying the bulldogs, because you don't want an artery to tear under pressure of the celiac axis. So that's the splenic artery. Very tempting to take a suture in situ, very tempting to put a mixture around, very tempting to put a clip, but nothing of that sort is done. I've put bulldogs everywhere. And now with a knife, I'm just cutting the splenic artery so that I will hopefully get some good leeway and the tumor will move away to the left after I divide. So now the splenic artery is being opened, and with a suture, I will be closing the opening of the splenic artery. So that's the open splenic artery stump, which instead of applying a clip, anything, nothing of that, I knew this is radiated tissue, just sutures and then close it under vision, and the bulldogs are in place. So when you close an artery close to the origin, always have a bulldog in place. Closing an artery under pressure is not the wisest of things to do when you do vascular surgery in pancreatic cancer. But now the whole tumor still did not move away. Now I thought I was doing well, and everything is moved away, and see what happened now. Can you guess what happened? Left gastric. Hepatic is this side. The left gastric I had delineated before. Now I wanted to save the left gastric also. Now I had a slightly uncontrolled bleed, but the bulldogs were secure and safe. So splenic is safe, celiac origin is safe, hepatic artery is safe, but I have a left gastric which has given way. And the easiest answer is band kar do, because everything else is intact. But my one bad experience of a patient with a bad fundic ulcer was making me work hard on that left gastric artery also, technically. At this time, we said, okay, left gastric is divided. We took care of it. And then we went ahead with cautery to get the specimen out quickly. So you will see the crus of the diaphragm. All this becomes easy after the vasculature is divided. So everything moved away. And now I got my CVTS surgeon who works with us once every week on a Thursday for more than 10 years, the same surgeon. Is a superb surgeon, incidentally trained in AIMS, but a friend of mine from Sion, and then he was in Mayo as well as Cleveland. Dr. Jayesh Dhareshwar, he is a part of my team. So whenever I do major vascular work, it's always on a Thursday, because Jayesh gives one day for thoracic and GI surgery only to do visceral vascular surgery. So that makes a huge difference that I moved away, and he just does a running suture of a primary arterial anastomosis. The artery worked, everything went fine, and this was an R0 resection at the end of it. Now, can we technically do this? We can do this, but never fight with your own ego and your capabilities. If I was feeling tired after this and I had an unexpected bleed when everything else had gone so well, I just said, calm, do not panic, don't put vascular crushing clamps over there, just control it. step away for a minute and get someone else who's waiting there the whole day for you if required, to just come in and peacefully do it. By then your coffee is done, hopefully not a cigarette, and then you're back. So then all clamps released. At the end I'll show you the picture which is from the left side of the assistant. So now the picture which I'm going to show you is from the other side. Look at that. Left renal vein, celiac axis, right hepatic, common hepatic, re-implanted left gastric, surgical bled, and SMA triangle tissue cleared. So you can do these cases when things respond well, and when you start doing the simpler pancreatic work more and more, and gradually go to vein, and from vein you will start going to arteries. Thank you very much for your kind attention.
Thank you, Shailesh. That was wonderful. Any query, questions, anything that you would like to ask him?
Shailesh, when you do LV3 dissection and there is a leak post-operatively, do you think the chances of hemorrhage are higher?
More than hemorrhage, I have not seen hemorrhage with an LV3. Aneurysm, I have seen a couple of patients come 2-3 months down the line. I have been lucky that I have seen in one case which was a left pancreatectomy, and the splenic artery area had an aneurysm. This was also a little advanced tumor, and a lot of divestment and stripping was done. So I have seen that one.
Just to make a point that
Yeah,
people
yeah.
should be aware that
So the minute you think of divestment, the follow-up for these patients, especially if the post-operative recovery is not smooth, should be more intensive, including your baseline scan at discharge to know that your vasculature is okay. And then you follow them up in case there is a problem, because a divestment means potential for more vascular problems, but a divestment also means avoiding a vascular problem by avoiding an arterial anastomosis. So it's a fine line between heaven and hell. Okay.
Yes, please.
If you are planning a venous resection, artery is free, and your portosplenic confluence is involved, that too for a short segment, but the crucial area is involved. How do you do? Because we are having 3 ends.
So vast majority of the times I would just divide the splenic vein and leave it alone. And there are 2 things that I will try to do. One is that if your upper end of the portal vein or the upper end of the splenic vein is free, the coronary vein is always usually draining into the portal vein. Uncommonly it is draining into the splenic vein, but more commonly it is draining into the portal vein. So you have the portal vein, you have the splenic vein, you have the SMV, you have the IMV, and you have the coronary vein. So if you safeguard, not in all cases, but in some cases you will be able to safeguard the coronary vein, and then dividing the splenic vein is not an issue. The other thing that you need to safeguard, even if you don't get your coronary vein, is the gastrohepatic omentum. Our instinct while doing these cases is to mobilize the gastrohepatic omentum to get everything out for your vision. But do not divide that gastrohepatic omentum as much as you can, because it contains collaterals and blood vessels which have not yet opened up. But once you divide the splenic vein, over a period of time the stomach will find its way to drain itself from the gastrohepatic omentum into segment 2 and 3 of the liver. So that's the other thing. The third thing you do is that your right gastroepiploic, if you're doing a left pancreatectomy, your right gastroepiploic vein can be retained or it can be reconstructed with the help of microvascular surgeons by even draining it into something like the colic vein or an omental vessel. So by that you will still be able to decompress and avoid your worries of splenic vein being ligated. But the easiest thing is to divide the splenic vein and do a primary end-to-end type 3 anastomosis. Sometimes you get it at a junction, and then you have to adjust the cut on the SMV in such a way that it's a tangential cut, so that you have a much bigger common ostium of the splenic vein and the portal vein, but this is also cut this way, and you can just bring it together. Now, if you need to put a graft in between, you have a choice to put in a PTFE, but we have even prepared 2-3 times at least, just a peritoneal graft over a tube, and then put that graft in between as a place for a type 4 anastomosis.
Sorry, Shailesh, peritoneal graft? I mean,
So you
making
just
a tube out of it.
Yeah, you just make a tube out of the peritoneum, or you
Fine.
can
How
even.
long you can manage?
We've managed, I mean, for a type 4 anastomosis, if the defect is more than 3 centimeters, it's better to have a graft ready.
Proper graft.
Yeah. I think there are surgeons who will say that for 3 and 4 centimeters, I mobilize everything, cattle brush, and it will come primary. But my sense of comfort goes down after anything that is more than 3 centimeters. We might
Absolutely. There's
succeed,
some bit
but
of tension there, and you can avoid it as you rightly
yeah,
say.
and at
I
least
agree.
be prepared, because in case you do it and then you are unhappy, then you want to recorrect it then and there. There is no second innings in these operations. Do it well, then only, even if the operation takes longer, even if you have to redo it, do it then. Afterwards, it's a disaster.
I agree. There's a rule of thumb that I saw Donald Weaver and Jacob both do. They shouldn't just come together, they should kind of overlap. That would mean that after you're finished, the tension is adequate or optimum.
Exactly.
If it's close for comfort, it's better to, as you rightly said.
99% perfect anastomosis means imperfect anastomosis.
Absolutely, I agree.
So that's one. And do not avoid, avoid kinks. The other thing that people don't realize is that you might do a good anastomosis. Then you are swinging your jejunum for your pancreas anastomosis, biliary anastomosis, stomach. Sometimes when you swing that jejunum, if you have not done it primarily, it will become like a corkscrew or collapse. So you need to be sure of your orientation when you do. You need to be sure of the orientation of the mesentery, and then you do. And that's the other thing. If you take 2-3 minutes more before you start doing, that is better than doing it hurriedly under pressure. Some tachycardia, some joke, some anesthetist saying something, some assistant not assisting well, suction stops to work at that time, sister goes for lunch and a new sister comes. 1 zillion things happen, and you as the hasmat, roz ka hota hai sabka. So actually you should laugh. So the thing is, it's all about leadership and organizing it well. When you fail to plan, you plan to fail. Simple.
Thank you very much. A big round of applause, gentlemen. Now we move on to the next presentation, but was your question, we want trying to ask something? It's okay. Dr. Pradeep Jain, again needs no introduction, is going to demonstrate robotic Whipples.
So before he demonstrates, just a small slide. Yes, sir.
Yeah, please do. Yes,
yeah, it's regarding Michael E. DeBakey. So we're talking of grafts, Dr. Shailesh. So he's best known for a pioneering cardiovascular surgeon, but his contribution to the pancreatic surgery are quite so fascinating. So DeBakey became the world renowned for his revolutionary work in vascular surgery. He was the one who used the Dacron grafts, and he was once called for a patient who
Neeraj was the only living father of vascular surgery. He lived till 92, and every year on his birthday he produced one instrument. So any guesses how many he produced? He was 90. Don't say 90 because he was not born with an instrument. So around 64.
64.
So
okay,
DeBakey forces, DeBakey clamps, and what have you.
So this is this success was a part of larger pattern that we saw in pancreatic surgeries became more safe and effective. And we have with us the most safe and effective surgeon, Dr. Pradeep, for the next presentation.
Thank you, Neeraj. First of all, I'd like to thank Dr. B.B. Agarwal, Dr. Neeraj Dhamija to give me this opportunity. Can I have my slides? So by presenting this video, I don't want to suggest that robotic Whipples is the best thing. Actually, there is very little data available on the, proficiency of robotic Whipples. There's only one randomized control trial right now, which has just analyzed 60 patients, in which they have shown that the comprehensive complication index is same between open and robotic, but as such, the higher incidence of grade B and C pancreatic specific complications. But moreover, it takes more time and more money. But in the setting of very high volume centers, both open as well as the robotic pancreatic duodenectomy, they are considered to safe options. And the few ongoing trials which are going to give more insight. This is a portal trial and a diploma 2 trial, which is still ongoing, and they will come out with the new insights. So now about the procedure. This is the table position we take. We keep the patient supine, head and slightly on the higher side, and right side up as compared to the left side. And these are the port positions. We just operate with this with the 4 ports with 2 assistant ports, and all 4 ports are almost in the linear fashion, just above the umbilicus. And these are the standard steps of the pancreatic adenectomy. And this is the video. The first thing we do is that we just open the. It's not running. There's no cursor. कंट्रोल मेरे पास नहीं है देखना जरा प्रॉब्लम Can anybody else present this?
Can I request Dr. Deep Goel to make his presentation if you're ready? Arvind, you're ready? Loaded?
Yes, sir.
Oh, take care. This happened to me once. Be careful.
My topic is RAMS, robotic RAMS, but it's not a classical RAMS. But my idea of presenting this was how to go behind into the retroperitoneum and do posterior RAMS. This is a young lady with a mucinous cystic lesion of the tail of the pancreas. FNAB showing mucinous tumor with some atypical cells. It's greetings from my hospital. These are the port positions for XI robot, and you will do the same position for laparoscopic as well. This is a vessel sealer which we had taken. This was our initial cases. Today, if I have to operate, I will not use a vessel sealer. Maybe with the unipolar scissor, I will do it. You can see the cystic tumor in the background there. So first we are mobilizing and opening the gastrocolic ligament, and that's the left gastric pedicle. Just trying to separate and get more space there. Now coming to the inferior border of the pancreas, after mobilizing the splenic flexure of the colon and going behind the pancreas, and if you remain in a good plane, you will see all this is avascular. You can see the DJ, you can see the inferior mesenteric vein there. Keep going in that plane as far as possible, and this is where you will start lifting your gyrotas fascia as well as adrenal gland, and that is what posterior RAMS is all about. Since it was not frankly malignant, we have not done a classical RAMS where we lift the pancreas from the SMV and go to celiac trunk and denude all the branches and take the vessels. And at some point of time you feel that you need to retract the stomach, so taking a stitch from the anterior abdominal wall. That's the gyrotas fascia, that's the IMV, DJ you can see here. That's the DJ, IMV, going behind onto the anterior surface of the kidney, left kidney. And as I was saying, this vessel sealer has probably slowed us down, but since it was our initial cases, we were little feeling secure with the vessel sealer. These are the vessels going to the adrenal. That's the adrenal gland being lifted up along with the pancreas. That's the adrenal gland. These are the adrenal vessels, and that was another advantage of vessel sealer. We were able to take these vessels with the vessel sealer. So dexterity of your instruments, vision, magnification, stability of the platform, these were all some of the advantages of robotic surgery in this particular case. Not that we cannot do this laparoscopically. Again, completing the dissection of the short gastric vessels to have more and more liberal exposure of that area. Here you can see the anterior surface of the kidney. So we are now trying to mobilize the spleen. So once this step is done, you will see the whole specimen along with the spleen and the distal pancreas will be there. We are trying to now come out from inferiorly behind all the dissected tissues and come out medially. You will see it in a minute. Now, see how the instrument movement, it's trying to gauge how much tissue is remaining there. That's the caudate lobe coming in the view. Then we realize that we need to do some more dissection. Now coming to the origin of a splenic artery there. Assistant is holding the suction and also pressing the pancreatic neck and body so to get more access. And that's the beauty of this instrument. Coming behind to see the splenic vein. That's the splenic vein you can see here. There's some bleeding happening. So we decided to put a gauze piece there and come back later, finish the dissection of the artery. So again, like we do in surgery, if you are not progressing well in a particular step, go to some other step and come back here later. Just a gauze piece here at that point of time, and we concentrate on the artery for the time being. Yeah, we are back to the artery. Gently holding the artery up with the left hand. And look at the movement of your hand with this robotic instrument. Wrist movement, and you are out onto the other side. Another important point, when you apply these clips, they can be sometimes, if there's a malfunction, if you pull, they will rip the artery apart. So be very gentle and take it out safely and then apply another one. That's very important. And now, after we have taken the splenic artery, this is the DJ flexure. We are now trying to see whether the bleeding which was happening, which was not much, has it stopped, coming back, and as you will see, a splenic vein there and no bleeding at this point of time. So we can safely go ahead and clip the splenic vein and use the vessel sealer for distal. And now I think there's enough space and we will be able to come out from the superior border and just passing a sling to separate the neck. We use stapler to transect, and now there is some evidence that if we do graded compression, possibly the chances of pancreatic fistula are lower. That's the tumor you can see there. These are the clips which he had removed, kept there. So graded compression avoids the fracture of the pancreatic tissue and hence probably lesser leak. And then you just take away rest of the attachments from the surrounding area. I think my procedure is already done. And then you make a small incision, cosmetic incision, phenestin incision, and protect the wound and take out the specimen and drain the surgical bed. You can see the anterior surface of the kidney completely devoid of Girota's fascia there. And that's a small incision, and that's the visualization of the bed. It's the pancreatic stump and a small drain capped. Thank you.
Thank you, sir. Any questions? Thank you, sir. Thank you. So we'll continue with the presentation of Dr. Pradeep Jain about robotic ripples.
So the first step is to open the lesser sac, divide all the adhesions between the stomach and the tonsil mesocolon with the scissor. Then we just mobilize the right sided colon, hepatic flexure first, to have a good cauterization. And the cautérizations begin at the level of D2. And all this can be done by a monopolar scissor, or you can do it with the vessel sealer. This is the mobilization of duodenum which is going on. And we have to lift the entire fibrofatty tissue from the IVC up to the aorta and take out all the tissue between these two structures. And again, this can be done with the instrument like monopole scissor, hot shear, or you can use the vessel sealer in this. This is, we are clearing the tissue in between the aorta and the IVC. The entire intra-aortic cable lymph node has been taken out. This is the completion of the lymph node removal from this area. Now after this, we just open the this hepatic ligament and do the division of gastric antrum. This is the conventional way of doing it. We can do the pylorus preserving also, but this is how I do it. And after division of the stomach, we just make a tunnel, retropancreatic tunnel first. This is a tunnel which is posterior to the neck of the pancreas. And after making it a good tunnel, then we go for the suprapancreatic area and dissect the hepatic artery. All this can be done with the monopolar cautery hot scissor. And this gastroduodenal artery is being divided, and the entire common the hepatic artery proper is being dissected, being separated from the portal vein. All these structures are bared actually. The entire tissue around them has to be removed to have a good lymph node clearance. Now this is dissection of upper part of the CBD. And this is hooked. And lower part is sutured and the CBD is divided. Not all this, in this case there was a abnormal, there's a variation of right hepatic artery. So the entire tissue is removed from the right hepatic artery, and this is a tissue around the portal vein which is being removed. And now we make further dissection over the superior mesenteric vein and hook the pancreatic neck. And then we go downstairs to mobilize the first part of the jejunum. And this entire dissection is being done with the vessel sealer. The proximal 10 centimeter of jejunum is being excised. This is the mesentery of first part of the jejunum. And after dividing this jejunum, we just push the jejunum, the supracolic compartment. This is further extension of the cauterization and removal of tissue from the uncinate process. Now the division on pancreatic neck, this can be done with the monopolar cautery. This is the beauty of the cautery of the robotic system. The hemostasis is much better than the ordinary cautery we use in laparoscopic surgery or open surgery. Now we have to cut the pancreatic tissue gradually so that we can identify, if possible, the pancreatic duct and cut it without putting a cautery there. But in this case, we will not be able to see, so we cut it with the cautery. Now this is separation of uncinate process from the superior mesenteric vein. And this is not one of the best uncinate process dissection, but still we are just clearing the superior mesenteric vein. This was the case of periampullary tumor, so it's not a big issue. So ligation of IPDA. The entire uncinate process is being separated from superior mesenteric vein. hemostasis is maintained, and the specimen was kept in a bag. And this pancreatic stump was mobilized, and now we started the pancreatic vaginostomy. As the ductal size is more than 3 millimeters, so we decided to go for ductal mucosa. And while making this ductal mucosa anastomosis, we just take the sutures first. Do not tie them. Just tie all 3-4 sutures and clip them separately so that we can tie them later on one by one. So this is the posterior layer. We always do a stunted anastomosis. This is the anterior layer of ductal mucosa pancreatic vaginostomy. Again, we just, all the sutures are not tied, just placed and then later on tied together. This is the last layer. After this, we just do hepatic vaginostomy. We always do in a single layer, continuous fashion. Because the duct size is more than 1 centimeter, we can do a continuous single layer anastomosis. This is the anterior layer, continuous again. Now the jejunal limb is taken anterior to the transverse colon, and gastrovaginostomy is fashioned by stapler. This is the closure of enterotomy, single layer. Now this is a ductal mucosa anastomosis. Sometimes the ductal size is not great, it is less than 2 millimeter, so we have to make a Dunkin procedures. For that we do pancreatogastroscopy. This is one of the anastomosis of pancreatogastroscopy. And this pancreatic stump is mobilized nicely, more than 2 centimeter. Now this is the posterior layer. This we do in interrupted fashion. Some people like to do it with continuous, but we, as a policy, we do a interrupted fashion. This is the third layer. This is the second layer we're making. And before completion of second layer, we just place a stent inside the pancreatic duct. This is the first layer we're making now. Again interrupted. This is the completion of anastomosis. Thank you so much for watching video. Thank you.
Any questions? Sir.
Very nicely done, and I think in well-selected cases, I completely agree with you. I myself do a fair bit of robotic pupil resections, but I have a selection bias. So I would do the simpler cases for robotic, and the not so simple cases I would do open.
This is what we are doing.
Exactly. So I think the message here is that horses for courses, and then we are fine. Because finally, while doing, if we are happy and if we are enjoying the surgery, the results are better.
It's basically you have to complete all the steps nicely. That is all. Whatever is the way.
Exactly.
Whether open, laparoscopic, or robotic. This was actually my second case video which I'm showing. I took 10 hours for this.
Which is very fine. I mean, we have now reduced to 6-7 hours in well-selected cases now. Takes time. Do
you do everything alone or you have a team?
We have a team actually, but
So do you
the
take
entire
turns
dissection.
in doing part of it, like I have now a situation where I will have a team which will do the resection
No.
and then a team which will do the anastomosis or vice versa.
No,
So
right
that
now,
stays
right now,
fresh.
right now, I'm doing everything alone. But gradually, everybody is developing. Now they will start picking up, and
Yeah, that will make it
yeah.
easier, and then it gets faster also.
Yeah. Thank you so much.
Thank you. Thank you. So before we call upon the next speaker, so Dr. Arvind Kumar, yeah. So this is the story of Frederick S. Travis. So he was the first person to perform a successful pancreatic surgery ever documented, and this was in 1888. And this was an incredibly risky undertaking, as the pancreas was considered as a no man's land. Frederick Travers was also a pioneer in abdominal surgery, performing some of the earliest appendectomies in England, and he famously saved the life of the King Edward just before the coronation in 1902. He was remembered as brilliantly compassionate surgeon who made significant advances in medical science. And I know one of such surgeon, Dr. Arvind, who is brilliant and compassionate and versatile in performing any kind of surgery inside the abdomen, including lap or minimally invasive Whipples or robotic Whipples. So he will be presenting us with the techniques of anastomosis in Whipples procedure. Dr. Arvind.
Thank you, Neeraj. This is what I am presenting in front of stalwarts in Whipple surgeries. So, at the start, I am presenting this laparoscopic hepatogenostomy. Started. So, according to me, I put a drain before even starting the anastomosis, because after the anastomosis, if we put the drain, we have to manipulate the bowel, and the anastomosis might get dismantled at some places. So, first I took a suture in the midline of the common hepatic duct, so that my anterior wall of the hepatic duct is opened. And then I'll start with the running suture, no tightening of it. Just take running suture, loose. It easier to do this way rather than if I tie the first knot, it is difficult. So this is the running suture I am putting. So it is easier, it is faster. I'm just presenting my technique of how to make it easy. And it is almost unedited videos with some speed up 3 to 4 times. Yes. But all the steps you will see in this. So after taking this towards the other end, make it clear that do not pull the thread from the far, because otherwise it will break. So give slow traction on the suture, holding the suture very near to the area. After that, one suture again you put in the middle, interpret suture, so that it doesn't loosen up. So I took this suture in the posterior layer, interpreted suture 1, and then I will go on the right lateral aspect, take the angle suture, put it a knot there, and then knot with the free end of that suture. So this way my lateral angle, right lateral is secured. Sometimes you can put a lateral suture and take it out laterally through the abdominal wall. And then take anterior running suture. I have devised one instrument also for, you will see in a little, which can help you in taking the anterior wall suture without risking that you are taking the posterior wall also sometimes when the narrow part is coming up. So till the middle you just then you stop here, and then you take the anterior holding suture and take the suture with that. Just cut this thread. And now the retracting suture, you also take one interrupted here, and then tie that with also with the running short length of the suture. So that posteriorly in the middle you have taken one interrupted, anteriorly in the middle you have taken one interrupted, and the right lateral aspect you have taken one interrupted suture also. And then go towards the medial medial angle. You take one more interrupted suture here. I already put the drain first, because if you put the drain afterwards, after the anastomosis, sometimes it is very difficult also. Sometimes that anastomosis can be having some problem. So put a drain first. So the right middle angle I have taken the interrupted, and then with the free the needle one I have taken that, which I have taken the posterior continuous suture. Even after that, I'll tell you the what can go wrong, and you will see how to manage that. Till now we are thinking that I have taken well interrupted also, continuous also, and the anastomosis is going well, no loosened up the sutures, but still. And now this is my customized instrument, so that you can take only the anterior wall when the distance is small. So it helps you in taking the anterior wall suture also only. It doesn't take you well to the posterior walls. So this is very handy. And you will see that sometimes we thought that it is the anastomosis isn't complete, but still there's scope for 2 or 3 sutures more. So that way this instruments really help me a lot while doing this kind of anastomosis. In fact, sometimes in pancreatic anastomosis also this instrument helps. It is a channel also where you can push the saline also to clean up that area with the clot or something like that. So even see, still a scope for 1 or more sutures are there. There is also one questions which comes in my mind, whether to go do HJ first or PJ first. So if according to me, in my opinion, if we do HJ first, then you can mobilize this, retract this jejunum well, so to take the angles and everything. And if you take the PJ first, then if you try to manipulate the bowel, your pancreatic anastomosis can be disrupted. Or and second thing, what the advantage of PJ first? In doing PJ first, do you have an advantage of putting a posterior suture if some suture is loosened up? So both things having advantages and disadvantages. So see, can you see that even after taking all sutures, that loosened up the tissue suture. So again, by putting this, so sometimes even after taking intrepid sutures with running also, some of the suture got loosened up. So in the end, you have to see also. If something is loosened up, then you have to take another suture. And then with the loop, the loosened also loop. So this way, this is a watertight anastomosis you have created. Also, I am here wanted to hint that please, you should not be using a Hemolox clips near the CVD and to vessels, because when you do the anastomosis, those clips are being really large size. It creates a problem. The sutures get entangled with that. So you should be avoiding all those large clips, Hemolock clips. So now this is now PJ. So again in this I take a stay suture in the middle of the pancreas, and that suture is taken outside the abdominal wall. And then take again, like Dr. Jain sir has told, that clip the, you should not be tight the suture first, you should be clipped so that the posterior wall you can see very well to take another sutures. This posterior layer you can take with 40 PDS or Vicryl, or even silk also, 30 silk or 30 Vicryl or 40 PDS. So this I am taking in this case in all intrepid suture posterior wall. And for these anastomosis, you should be having fine forceps, where pointed forceps, so that you can hold the needle and suture well, because you are dealing with 4050 sutures. Also, for a choice of needle holder, you should be having a holder which is click on and click off, which is like as from Esculap, because if you use where lots of ratchets are there, sometimes what happens is when you open the ratchet, it jerks off, and it creates sometimes tearing of the tissue, which it is very fragile tissue. So it is, in my opinion, the Esculap needle holder are very good for this kind of, when you are dealing with 4050 with these delicate tissues. And in my left hand is a dolphin, or even you can use micro Radicolson instrument. And someday I am also having a 5 with a needle holder which is a 5 mm holder, but tip is 3 mm holder. So shaft is 5 mm, but the tip of the needle holder is 3 mm. So that is very good for this kind of handling this 50 sutures. And also when you're taking this ductal mucosa suture, you should be using a 50 double needle, because it is easier to pass from inside out. So taking sutures, first take out inside out, then cut the suture, make it a smaller, then take the other side like ball.
Very much like the vascular.
Yes. So 50 double needle, inside out, both the side, it is easier to handle. Because sometimes when the space is narrow, it is difficult to go using outside, inside, outside to in, difficult to go inside the lumen of the duct. So it is difficult. So better is to do inside out.
It stays on the anterior.
Yes.
I do the same in robotic.
Yes.
I just take an anterior suture and I use the prograsp to not only retract it but also use the prograsp to retract the liver as well. So the
Yes.
7.23 is not overhanging. The pancreas is lifted up by one suture. I keep it long one, a 4.0 PDS.
Do you do any boxing like modified Bloom guard?
No, I do a Stanley high river. I do it in robotic.
I take the suture outside the intermittent wall so to retract it. Sometimes you can take 3, I mean at both the angles and in the middle as well. Yes. Yes.
Have you tried V-lock?
Lots of bleeding is there posteriorly.
But I have had good experience with V-lock.
I tried. See, I'm not experienced as you. I have very less cases, but I tried each and every technique and every sutures.
I see that you are such a talented laparoscopic surgeon that V-lock will make your job easier.
I did them. Yeah, I did them, but bleeding happened. Oozing was there. So no. I take it more inside the jejunum part. Yeah, 10 to 15 centimeter. 10 to 15 centimeter. So like here you can see, I mean inside out is easy. Easy because you can take the width of the duct very well. Otherwise, if you're coming outside to inside, sometimes the length of the duct where you're piercing the suture is very small. It cuts through.
Say if it is 4 millimeters or up to 6, so would you use any dilator any time? Have you ever used?
Yes, dilate. If you cannot find the lumen or very small lumen is there, then you can use.
Which dilator would you use? I use the
I made my customized dilator.
Yeah,
customized dilators.
Shailesh, do you dilate anytime?
No.
You don't?
I think I just accept that whatever is there is created by nature there.
No, but like if it's very narrow, you're finding it technically challenging.
Use a 6-0.
Not the suture, the space. Suture is fine. Then you'll use some loops to watch it.
Yeah. If it is
That's
that
what I'm
small,
saying.
you will use operative loops.
Yeah.
And in the robot, I won't have that problem.
Oh, robot, yes.
And otherwise, loops, open surgery.
So now again that the suture which is holding it, because I have already taken inside out from pancreatic duct. Now it is easier to that needle bring and then take the inside out from the jejunum. So it is better in the anterior wall also to take inside out in the jejunum. So 5-0 double needle suture really helps. So this is also almost unedited video. I mean, taking all the steps, all the sutures. I have a question with Doctor. See, there's 2 routes through which jejunum can be taken up for the anastomosis. One is from the transverse mesocolon, and another recently I am trying to the normal route.
Yeah.
So, what are the advantages and disadvantages of both the routes?
We also have only a subjective experience. We have not done an objective study as such. But in the robotic procedure, we are more often bringing it from below. But in conventional surgery, I'm doing it through the transverse mesocolon. And I think both seem to work well. But I've not seen my delayed gastric emptying rates whether there is a technical reason. Because we bring it from below, whether there would be an effect or not. But I don't know.
Also in the gastrojejunostomy, there was a trial, retrocolic, anticolic. They eventually found it makes no difference at all. You should find the shortest route with minimal tension that you can achieve.
One more question, because in my patients, we are facing lots of gastric outlet obstruction. What are those? I mean, how can we decrease them? I tried stapler anastomosis also, hands-on anastomosis also. Sometimes later on, after the post-operative phase, we have to do the NJ tube. So that. No, it is obstruction.
Is it a longer afferent loop?
Sometimes the radiologist says there is an intersuspension also is there.
Yeah,
retrograde intersuspension is also there. Edema at the gastrojejunar anastomosis.
What is your delayed gastric emptying rate? This is not delayed gastric.
No, it is not delayed.
Mechanical obstruction.
It is mechanical obstruction. I am going to know how to decrease mechanical obstruction. Huh?
You have had to reoperate for this.
No, only the NJ tubes it helps, and patient is settled then.
Probably there is a kink, no? There is something which is rotating.
There is a technical issue here.
Yeah, that I mean, sometimes even with the stapler anastomosis it happens sometimes. I mean, not in all the patients, but
30%?
yes.
3 patients out of 10.
Yes. Even 40%. A week. I mean, we discharge the patient, angio tube, just wait for 1 or 2 days in the hospital. Yeah, but why it is happening? I mean, it is not happening with other surgeries like we do distal radical gastrectomy or total, I mean, that way. And this is the loop, I mean, we have taken up for the anastomosis. Put a one suture. Here also I want to stress that when we are taking up the small bowel for GJ anastomosis, place or identify those loops which is afferent or which is efferent by putting a suture, small suture, big suture length, so that you will identify which afferent loop, where to put afferent loop and efferent loop for the anastomosis. Thank you so much. Thank you so very much. Thank you.
Atony, that's what he was saying, but otherwise it can be mechanical.
It is mechanical because after putting NJ tube it settles
See, usually if it is settling with an NJ tube, it's kind of a stent you're passing in, so it has got to be a twist, you know. That's what I'm saying, some kind of a volvulus rotation.
But it is at the opening. It is not that the kink is there. If kink is there, why the edema will be there?
So you mean you've seen that edema there?
Yes. Our gastroenterologist, while doing endoscopy, they have shown us.
So what you are asking is, there's more edema locally at that.
Yeah. What can I do? What I can do to prevent that? I mean.
One more thing is a lot of fluids being pushed during surgery. That you need to be careful with the anesthetist. Why should it be different?
So duration is the difference. So maybe the anesthetists are given.
Very important. Lots of fluids going in can be a challenge.
Surgeon is the same?
Yes, surgeon. Myself. I'm talking myself. My complications.
C-section, do the PJ, FJ, somebody else doing the GJ.
Yes.
So better find out, no, who's doing it.
No, but sometimes I also myself did.
I'm not doubting that. I'm just saying that just some small attention to standardization of your GJ might also help, apart from fluids and the delayed gastric emptying which is inherent to a Whipple procedure.
Sir, you had to re-expulsion was done for
No. Only NJ tube. Only NJ. Yes.
See, invariably, endoscopist, when passing in a scope, would find some edema around that anastomotic site.
I think, sir, intraoperatively, if you pass an NJ and keep it as a routine, then.
Okay.
So if you do that, I mean, you're yourself doing it, so might as well. Any comment or quick question? Because mostly it was discussed as it went along.
FJ with the T tube. FJ with the T tube.
If you're doing NJ, then probably that takes care of it.
No pylorus preserving. Rather, I take more of the stomach part also. Yes.
Almost an enterectomy.
Yes, almost enterectomy. I did, but these were same, and I didn't find anything. I mean, even gastric emptying is almost same or sometimes delayed because of maybe leak or whatever it is. So one of my Russian friends were there. They were telling me that take more of the stomach. It will help you in less gastric delaying time.
You don't have any stomach to have that problem, no? That's what
lots of.
Any other question or comment? But I don't think that's a solution to the problem, because if you're thinking.
I mean, we have to find it myself.
Well, thank you very much.
Thank you.
Excellent. With that, we close the session. Thank you. Over to you, Neeraj.
Let me thank you then. Let me thank you then.
So I barged into, interrupted just to thank Dr. Shailesh for being here. And I was just thinking, every year we write an audit report at in Gangaram, and I'm a co-chairperson of the audit committee and quality committee. And this year our department got the best prize for the best report. So we mention in that what did we do in the last year. So next audit report will have a very significant paragraph dedicated to that. A legend, Dr. Shailesh Srikhande, graced us with his entire day. So I felt it. It's rare to have. I am not as old as I am respected. I'll be I'm 61. But I was thinking when I started assisting Vipuls, when 50% of patients were just opened and closed because there was no CT, and Dr. Adarsh Chaudhary was our lecturer, registrar. So I have seen him closing 50% patients. Then things moved on, and now we have come to so much of selectivity, specificity, and customized surgical approach based upon multidisciplinary teams, and now laparoscopic, robotic. And we I also belong to that generation when I boasted in Gangaram when Dr. Manish said कि sir यहाँ Vipul नहीं हुआ. So I did a Vipul in 16 hours just because we selected a patient, best possible patient, जो सबसे simple हो सकता है, और उसको करके हम खुश हो जाते थे. Same thing we did in the first robotic. And now so I have seen the entire journey. And in that journey, your father used to love me, and he used to make me feel that he's seeking me in conferences. So that was his greatness. And now, like father, like son, so you have graced us today. Thank you so much. And you are part of our legendary audit reports now. Thank you for being here.
Good evening, everybody. I'm Dr. Vasu Vashisht. This will be the last vote of thanks. It's just a moment. It's an honor for me to be standing in front of all the stalwarts. As we all say, Pancreas is a no man's land, but the stalwarts that are sitting here are not just entered that no man's land, but also have excelled in that. So thank you, sir. Thank you, everybody, all the speakers. I would like to thank Dr. B.B. Agarwal for guiding us through this. Dr. Neeraj Dhamija, who has organized it so well. His organizing skills are just incomparable. And I would like to thank our Board of Management for giving us this opportunity and the space, the time, everything for carrying out this academic conference. I would also like to thank all the students who have attended the entire day of conference, but it was very knowledgeable, and I hope everybody has learned something from it. So thank you very much, everybody. We would start the wet lab now, so sir will let you.
We'll just have a 10 minutes coffee break. We're setting up the wet lab. Everybody can enjoy a cup of coffee. Then we'll start sharp at 3:30. Okay?